Okay, guys. Hello. Good evening. How are you all doing? Just give me a thumbs up. We'll just see how is our audio and video. Am I audible? Good evening. Good evening. Okay. चलो चलो बच्चों we'll start with this session. Right. We'll start with the first question. Right. We'll start with the first question. So during airway assessment of a 50-year-old man with obstructive sleep apnea, you perform Mallampati test, but he is unable to open his mouth fully due to TMJ stiffness. Only you are able to see the hard palate. What is your interpretation and plan for this patient? Patient came to you having OSA, obstructive sleep apnea and all, means he's obese and all, TMJ stiffness. Only you are able to see the hard palate when he's opening mouth. Basically under Mallampati, which class he goes to. Remember guys, in Mallampati classification, there are 4 classes, right? Mallampati 1, 2, 3 and 4. In the PAC, the Mallampati classification plays a very important role for airway assessment. So guys, remember, when do you call Mallampati class 1? When the patient opens his mouth and you are able to see all the structures which include what? Tonsillar pillars, uvula, soft palate and hard palate. That is class 1. Class 2 means what? Part of tonsillar pillars is visible. A part of uvula is visible means what? The tip of uvula is not visible. In class 2, tip is not visible. Next, soft palate and hard palate are visible. That is class 2. Class 3 means what? Base of uvula is visible, soft palate is visible to you and hard palate is visible. That is Mallampati class 3. Class 4 means only hard palate is visible. That means the patient does not have adequate space for it doing laryngoscopy. That is class 4. There is one more class that is called as class 0. Class 0 means what, guys? All class 1 structures. Yani when he opens mouth, you are able to see pillars, uvula, hard palate, soft palate plus yani MP1 plus tip of epiglottis. That is Mallampati class 0. Okay. So anyway, guys, coming back to our question, you are able to see only the hard palate. So that means what, guys? He is having Mallampati class 4. But here in 2 options, there is given Mallampati class 4. Option A and option B. So when you know the patient is having Mallampati class 4, what is your plan, guys? Will you go for a normal routine induction? A brainless man will go for a normal routine induction. Why? Because we have already anticipated a difficult airway. Why do we go for a normal routine induction? When he is having a difficult airway, you go for a difficult airway trolley ready. You are basically anticipating all the things. You take a video laryngoscope, you take a bougie, everything, you keep it ready. So basically remember, you have anticipated difficult airway. So you go for what? Option B. What are the things that you keep ready, guys? This is the difficult airway trolley where you are keeping all necessary airway equipments available. That means different sizes blade, different sizes laryngoscope, the supraglottic airway devices or the LMAs. Apart from that, you also keep stylets and bougie. Stylet and bougie for intubation. Right? You also keep a video laryngoscope ready, guys. If at all it's available, you also keep it. Okay, so answer is B. But guys, before proceeding further, I wanted to ask you, is just Mallampati classification an indicator or for difficult airway, or apart from Mallampati there are some different indicators? There are some different indicators also. Basically guys, Lemon classification is known to predict difficulty of the airway. Okay, Lemon means what? Look externally for any trauma and all. L stands for look, E stands for evaluate the 3-3-2 rule. Okay, M stands for Mallampati score, O stands for obstruction and N stands for neck mobility. Based on the Lemon score, we will tell the patient is having difficult airway or not. In this Lemon score, the most important one that we commonly test is the Mallampati score. Okay guys, now what do you think, guys? How is this airway? You know this person? How's this person's airway? Easy or difficult? Obviously, it will be a difficult airway. Why? Because he is a tobacco chewer. Tobacco chewer will be having submucous fibrosis and they will be having a difficult airway. Okay. Coming to the next question. Guys, are you with me? Difficult. Okay. Right. Acha, you guys remember he's from what? कौन सी वेब सीरीज में आया था ये? चलो ठीक है, कौन सी वेब सीरीज में आया था? मिर्जापुर, राइट? चलो नेक्स्ट. 70-year-old man with coronary artery disease is on aspirin and clopidogrel. He is scheduled for elective TURP. What should be done pre-operatively for this patient? यानी कि basically these questions are related to your PAC, guys. So he is telling patient is on aspirin and clopidogrel. What's your advice? Will you tell him to continue both the drugs? Never. Why? Because one drug has to be stopped. Which drug has to be stopped? Clopidogrel. At least how many days before surgery? 8 days before surgery you have to stop clopidogrel. Otherwise patient will have bleeding during the surgery. Okay? Will you tell the patient to stop both the drugs 24 hours before surgery? No. You won't tell the patient to stop it 24 hours. Okay? You tell the patient to stop clopidogrel. Remember guys, ideally it should be 8 days, but the option that is going near to 8 days is 5 days. So stop clopidogrel 5 days before surgery and you can continue aspirin. Aspirin can be continued. Normally the dose of aspirin that is being given to a patient is 75 milligram. That is a baby aspirin dose that has to be continued. Okay. Now guys, there are some medications that need to be continued and there are some medications that need to be stopped before surgery. Now, what are the medications that are continued before surgery, guys? Remember, based on the history of comorbidities, you ask the medication that has to be continued and that has to be stopped. So, always remember the medication that are continued are all active agents always approved. That means antihypertensives can be continued except, there are some exceptions, guys, except for ARBs and ACE inhibitors. They have to be stopped on the day of surgery. Otherwise, they will cause rebound hypotension. Okay, next is what? Next, A stands for anti-cholesterol medication. Anti-cholesterol means anti-lipidemic medication. Statins can be continued. Next, A stands for anti-anginal medications can be continued. Next is anti-epileptic can be continued. And last is anti-thyroid medication or euthyroid medications can be safely given before surgery. There are a few medications that we need to stop before surgery. Okay, what medications need to be stopped before surgery, guys? Basically, we used to tell the patient before surgery, your home clothes are not allowed. We will give you a hospital clothes. Yani you need to remember the drugs that are stopped are also like home clothes. My clothes are stopped. Okay, M stands for monoamine oxidase inhibitor. Monoamine oxidase inhibitor has to be stopped at least 3 to 4 weeks prior surgery. Why? Because if at all you are not stopping, usually in anesthesia we are giving pethidine. It might react with monoamine oxidase inhibitor and severe sympathetic reaction can occur. C stands for clopidogrel has to be stopped. Now guys, I told you clopidogrel has to be stopped 8 days prior surgery. L stands for lithium. Lithium has to be stopped 24 to 48 hours prior surgery. Okay? Why? Because it can prolong the effect of muscle relaxant. Next, O stands for oral hypoglycemic has to be stopped on the day of surgery. Why? Because patient is already in a fasting state. T stands for TCAs should be stopped 3 weeks prior surgery. H stands for heparin. Anticoagulants such as heparin should be stopped 6 hours prior surgery. And S stands for smoking. Smoking should be ideally stopped. Ideally, it should be stopped 6 weeks prior surgery. Okay, so these are the things that are usually stopped. Apart from that, you also need to remember there are some things in the PAC. In the PAC, we have to tell the patient about the fasting. After taking all the history and all, you tell the patient to be in a fasting state so that the patient does not develop any aspiration risk. So if the patient is adult and he is on solid food, how many hours of fasting is mandatory, guys? 8 hours. Previously it was 12 hours, but now it is 8 hours. Okay, for semi-solid food, 6 hours of fasting is mandatory, whereas for liquid it is 2 hours of fasting. If there is a child who is brought to you for surgery, then how many hours of fasting is mandatory? For child, it is 2, 4, 6. If the child is taking only clear water, 2 hours of fasting. So remember, clear fluid, liquid or clear fluid, 2 hours of fasting, whether adult or child. If the child is on mother's milk, then 4 hours of fasting, and if the child is on formula feed, 6 hours of fasting is mandatory. Okay, coming to the next question, guys. A 65-year-old man with controlled diabetes is undergoing PAC, and again I am doing a PAC for this patient who is being posted for elective cholecystectomy. His ASA physical status is, basically guys, remember, if the patient is having a controlled illness, what ASA classification he belongs to? ASA 1, 2, 3 and 4. Come on. Very good. Most of you have given the right answer. Remember, it is ASA class 2. Guys, in simple language, what does ASA classification means? ASA is you are giving a certification to a patient that you are completely fit to undergo anesthesia, or you are this much fit to undergo the anesthesia. Now, ASA 1 means what? ASA 1 means patient comes to me and tells, doctor, I am healthy. That is ASA 1. ASA 2 means what? Patient comes to me and tells, doctor, I am having a mild disease. That is class 2. ASA class 3 patient means what? He comes to me and tells, doctor, I am having moderate to severe disease. That is class 3. ASA class 4 means what? That patient comes to my clinic and tells, doctor, I am at risk of dying. And again, I am having a disease which poses me a threat towards a death. Okay? Towards the risk of death. So that is ASA class 4. Class 5 means what? That patient will come to me and tell, basically that patient won't come to me. I will go to the patient and patient will tell, doctor, I am about to die. Yani he is a moribund patient. Class 6 means what? He won't tell anything. He is already dead. Okay? So ASA 1. ASA 1 means what, guys? Patient free from systemic illness. Patient free from systemic illness. That is ASA class 1. ASA class 2 means patient having systemic illness which is mild or under control. Okay, smoker and social alcoholic patient are also coming under ASA class 2. Class 3, as I already told you, patient having systemic illness which is not under control. Yani patient is having moderate to severe systemic illness. Okay, such as he's having moderately reduced EF, alcohol dependence, or BMI more than 30, or uncontrolled diabetes. ASA class 4 means what? Patient having systemic illness or patient having life-threatening systemic illness. Life-threatening systemic illness. That could be a recent MI or ESRD. Okay. Class 5 means what? A moribund patient. Without surgeries, the survival chances are very less. Example, ruptured abdominal aortic aneurysm. Okay. ASA class 6 means what, guys? Brain dead patient. Brain dead patient. That is regarding what? That's regarding the ASA classification. Okay. Coming to the fourth question. Which of the following is regarded as the most common intraoperative complication of spinal anesthesia? So basically we are done with the PAC. We are now jump into the topic of regional anesthesia, under which we are doing spinal anesthesia. The answer for this is what, guys? Most common intraop complication of spinal anesthesia. Come on, what's the answer? Some of you are telling A, some of you are telling B. Come on, guys, don't be in a hurry. Just look over here. I am talking about the intraoperative complication. If you are answering as post-dural puncture headache can occur as a post-op complication. But it is not the common post-op complication also. So I don't consider post-dural puncture headache as a common complication unless and until I am using a very wide bore spinal needle to give spinal anesthesia. So it's not an intraop complication. Now remember, urinary retention is the most common post-op complication of spinal anesthesia. Okay, most common post-op complication. Now intraop, we are having only two things, hypotension and shivering. Which is the most common, guys? Remember, immediately after giving spinal anesthesia, this would be my reaction. Because always happens, guys. Always this thing will happen. What will happen? Immediately after giving spinal anesthesia, I make the patient lie down, and what will happen? The patient's BP falls down. I'll be telling, utha le re baba, patient ko nahi, but BP ko. Okay? So the most common complication is what, guys? Intraop complication is hypotension. It is pretty much straightforward. Why? Because when we give spinal anesthesia, it produces a sympathetic blockade of the lower extremities. So now, guys, look over here. After giving spinal anesthesia, I will see first what? First and the most common complication is what? It is hypotension. Next is what? Slowly I'll see the patient is having bradycardia. Okay? So remember guys, if you see this complications and then manage, you might lose time. So what I do as best is what? Before this complications develop, I prepare myself that, okay, this patient will have hypotension, this patient will have bradycardia. So I'll prepare an emergency drug tray where I'll be keeping some drugs, guys. What drugs I'll keep? I'll keep a drug called as phenylephrine. Why am I keeping phenylephrine ready? Why? Because remember, the most common complication of spinal anesthesia is what? Hypotension. For hypotension management, the best drug is what, guys? Phenylephrine. The second drug that I keep ready is what? Atropine. The second complication of spinal anesthesia is what, guys? Remember, the most common complication is hypotension. Second is bradycardia. For bradycardia, I manage with atropine. Okay? The third complication that could occur in spinal anesthesia is shivering. As spinal is producing a sympathetic blockade of the lower extremities, all the blood from the upper part goes and pools into the lower part. Blood is one of the things that maintains our temperature or regulates our temperature. Due to that, the patient will have shivering. For shivering management, we give what, guys? Pethidine. Pethidine we are giving. Okay. Now, apart from that, high spinal and total spinal can also occur. High spinal means what? You have given spinal anesthesia, you wanted your drug to act till umbilicus, but it has gone up. Yani if the drug has ascended up, that is called as high spinal. It is characterized by two things together. What two things together? Hypo and brady together. Okay, that is important. Hypo and brady together. These are intra-op complication. Post-op complication, yani after operation, what are the complications of spinal? The most common post-op complication of spinal anesthesia is urinary retention. That's why in order to combat this, what we do, guys, nowadays, any patient who's posted for spinal, any surgery under spinal anesthesia, what I do is I put a Foley's catheter. Even though it is a source of infection, but still I put a Foley's catheter so that the patient does not develop this complication. Okay. Next is what? Headache. Headache can also be seen as a complication of spinal anesthesia due to the puncture in the dura. Okay, that is called as PDPH, post-dural puncture headache. If at all PDPH occurs, what is the best management? It is a conservative line of management, which is best. Okay? Conservative is regarded as a best line of management. Conservative means what? Coffee you are giving and rest you are giving, and you're telling the patient to lie down in a basically head low posture. Okay? But the definitive management is epidural blood patch, closing the dura with the help of blood clot. Blood clot, that is called as epidural blood patch. Okay? In the post-op, there is one more complication that can occur, that is called as cranial nerve palsy. Now guys, remember cranial nerve, which cranial nerve? Sixth cranial nerve. Why? Because it's having a long course. Okay? So sixth cranial nerve palsy can also be seen as a complication of spinal anesthesia. Now guys, as we are discussing regional, we'll discuss a few points of epidural also. Now guys, the epidural anesthesia, just look over here. Epidural anesthesia is given for what? Spinal is given for below umbilicus surgeries which are done within 2 hours of duration. Epidural is also given, mostly it is given for below umbilicus, which is done for a longer duration. Okay? Now guys, in epidural anesthesia, you can see this needle which is being used, which is called as Tuhoy's needle. Now, epidural, spinal is given usually between the L3 to L5 lumbar intervertebral space, but epidural can be placed at the cervical, thoracic or lumbar depending upon for what purpose are you using it. If at all if the patient is having any radiculopathy pain, neck radiculopathy pain, then you can go for what? Then you can place the cervical epidural. If the patient is posted for some cervical lymph node dissection, you can go for placing a cervical epidural. Thoracic epidural is placed if the patient is having rib fracture or thoracotomy pain is there, you place a thoracic epidural. Lumbar is usually given for below umbilicus surgeries as well as painless labor. Lumbar is usually used for below umbilicus long duration surgery. Below umbilicus long duration surgery as well as painless labor, you can use this lumbar epidural. Okay. Now there is one more anesthesia which is called as caudal anesthesia. Guys, caudal anesthesia is nothing but giving you are giving anesthesia, you are giving an epidural anesthesia in children at the level of sacral hiatus. So what about respiratory depression in high spinal anesthesia? Is it also a complication? Yes, respiratory depression is also a complication. It can occur in high spinal, but most commonly it occurs in total spinal anesthesia. If at all respiratory, if at all high spinal, if at all respiratory depression happens, then what? Then in the emergency directory we have already kept laryngoscope and ET tube, so you can just intubate the patient. If you don't want to intubate, you can keep an LMA also. Just ventilate the patient, because you have given the drug, you have given the local anesthetic in spinal anesthesia, which will act only for 2 hours. Till 2 hours, you ventilate the patient. Okay, so guys, what is the site over here? It is the sacral hiatus. Okay, sacral hiatus. Caudal anesthesia is given at the level of sacral hiatus. In the caudal anesthesia, what we need to remember is what is the last layer to be pierced as your needle is passing through the skin. The last layer to be pierced is sacrococcygeal ligament. Sacrococcygeal ligament. Okay, right. Now guys, coming to the next question. A 35-year-old man is undergoing spinal anesthesia. While inserting the needle, the anesthesiologist feels 2 pops before clear fluid is being seen at the hub. That is common, guys. While giving spinal anesthesia, we'll feel 2 pops. Okay, first pop at the piercing of ligamentum flavum, second pop at the piercing of dura. Now he is asking what are the layers pierced by spinal anesthesia. What are the layers pierced by your needle in spinal anesthesia? Now guys, remember, as I am passing the needle, if someone asks me what are the layers pierced by the needle, I'll always tell what? Some say spinal instigates lethargy during anesthesia session. Some say spinal instigates lethargy during anesthesia sessions. Okay, so most of you have given the right answer, which is answer B. Okay, we'll see. Why am I telling that? Okay, what is the first layer? Why am I telling some say spinal instigates lethargy? Remember, the first layer to be pierced is skin. Next is subcutaneous tissue. Next is supraspinous ligament. Next, interspinous ligament. Okay, the mnemonic is some say spinal instigates lethargy. Lethargy, L stands for ligamentum flavum. That is very, very important, guys. Ligamentum flavum is what? Why it is the toughest ligament. On piercing of this ligamentum flavum, you will feel a snap or you will feel a sudden LOR. LOR means what, guys? Sudden loss of resistance. ठीक है, आपको पता चल जाएगा. Once you pierce the ligamentum flavum, you will come to know. ठीक है, the second pop you will feel once the dura is punctured. So next layer is dura. Once you puncture the arachnoid, the last layer to be pierced in spinal anesthesia is the arachnoid. Once you puncture the arachnoid, you will be in the subarachnoid space where you will see the CSF. So just guys, just look over here. As you are passing the needle, what are the layers that are pierced? It is the skin, subcutaneous tissue or fat, supraspinous ligament, interspinous ligament, the toughest ligament. Just look over here, ligamentum flavum. Next, dura. Right? Once you puncture the dura, you will be arachnoid. Once you puncture the arachnoid, you will be in the subarachnoid space where you give the drug. That is regarding what anesthesia, guys? Spinal anesthesia. Now, yes, in epidural anesthesia, you just pierce ligamentum flavum and you stop. In spinal, you have to feel 2 pops. In epidural, only 1 pop. 1 pop, once you pierce ligamentum flavum, you are in the epidural space. That epidural space is between the ligamentum flavum and the dura. Now, guys, what are the contraindications of spinal? Spinal is contraindicated if the patient is in shock. Remember, spinal, most common complication is hypotension. But if the patient is in shock, don't give spinal anesthesia. If the patient is refusing, that is again a contraindication for spinal anesthesia. Patient having a fixed cardiac output lesion, a patient who cannot tolerate hypotension, don't give spinal anesthesia. Spinal is also contraindicated in very good raised intracranial pressure. If the patient's intracranial pressure is raised, spinal is contraindicated. You cannot give spinal anesthesia. Okay, spinal is also contraindicated if the patient is having bleeding disorder. Now guys, bleeding disorders or coagulopathies, meaning what? If the platelet count, theoretically it is said that if the platelet count is less than 80,000 or the INR value is more than 1.5, don't go for spinal anesthesia. Okay, or if there is any local site infection, don't go for spinal anesthesia. Okay, now guys, coming to the next question. right? A 28-year-old woman develops circumoral numbness, dizziness, and tinnitus during liposuction under local infiltration. Guys, liposuction can be done under local. It can be done under general also, depending upon the patient. If the patient can tolerate well, we can do it under local. So we are imagining that this patient had received local anesthesia and now these symptoms develop. What? Circumoral numbness, tingling and all. So what could be the symptom? So what's the platelet threshold for general surgery? General surgery, basically guys, it is said for general surgery, platelet count should be more than 1 lakh. Okay. Ideally more than one, like in the normal range, but it should be more than 1 lakh. So look over here. So what's the answer over here? Guys, if it was allergic reaction to local anesthetic, patient won't have circumoral numbness, tinnitus. These are symptoms related to the CNS. Okay? If it is a vasovagal syncope, patient will have dizziness but not circumoral numbness. That could be okay. Hypoglycemia also, patient will have dizziness, not circumoral numbness and all. So answer is what, guys? Local anesthetic systemic toxicity. When you give local anesthetic drug, okay, and it has gone intravascular, or you have exceeded the dose, or you have given local anesthetic at a site where it can be easily absorbed and gone into the bloodstream, patient will develop local anesthetic systemic toxicity. And remember, the first system to be involved is what? The central nervous system. And what is the first sign of getting involved of central nervous system? Patient complains of circumoral numbness. Now guys, my question to you is, okay, right. Basically, how will you manage if at all patient develops local anesthetic systemic toxicity? The treatment of choice is what? Intralipid solution. How much percentage, guys? 20% intralipid solution. My question to you was, basically at what are the sites where you give this local anesthetic which will predispose the patient to develop toxicities? Which are the sites which are regarded as highly vascular? Basically, remember, the toxicity is high when you are giving through the IV route, followed by tracheal route, followed by intercostal, followed by brachial plexus. If you give IV local anesthetic and given at a higher dose, it will lead to toxicity, followed by tracheal, intercostal and brachial routes. Now, something about local anesthetics. When you are giving local anesthetic to the patient, how will it go into the patient? Yani, how will it cross the nerve? First of all, in which form it is entering the nerve, guys? Local anesthetic enters the nerve in a non-ionized form, guys. Okay? It enters the nerve in a non-ionized form. Once it enters the nerve in the non-ionized form, it becomes ionized and it searches for the channels. What channels? Very, very important. The sodium channels. Then it blocks the sodium channels. Once sodium channel is blocked, depolarization is blocked, action potential is blocked, and pain is gone. So remember, non-ionized form enters the sodium channel and enters the nerve, and ionized ionized form will block the sodium channel. Okay. Now guys, we'll discuss about the classification of local anesthetic. They are classified into two categories. One is called as amino ester, other is called as amino amide. By looking at the local anesthetic name, you can say amino ester or amino amide. Why? Because all amino esters will have one alphabet of I in it. Cocaine, procaine, benzocaine, tetracaine and chlorprocaine. These are what, guys? And proparacaine. These are what? These are amino esters. Amino esters. Why? Because they are metabolized in the plasma by plasma esterases. Okay. Now in this cocaine is the first used local anesthetic. And remember, guys, whenever you give local anesthetic, they will cause some vasodilatation. But this cocaine, it is causing vasoconstriction. Cocaine is a potent vasoconstrictor. That's why many of the patients who are using cocaine abusers, they are at risk of developing hypertension and hemorrhagic stroke. Okay. So you need to remember, cocaine is a local anesthetic which can cause potent vasoconstriction. Rest all will cause what? Vasodilatation. Next, guys, amino amides. When do you call local anesthetic amino amides? Second classification, when there are two alphabets of I present in the local anesthetic category. What two alphabets, guys? I. Okay. Examples of local anesthetic having two alphabets of I are lignocaine, mepivacaine, bupivacaine, prilocaine, dibucaine. Okay. And if I give you an option and ask you which is the most common among these, the answer should be what? The most commonly used worldwide. Hospital में कहीं भी चले जाओ, ER में जाओ, OT में जाओ, Wherever you go, you will find this vial. Lignocaine is the most commonly used worldwide. Now, if the next question, someone is asking you, which is the most commonly used in spinal anesthesia? चलो भाई आंसर क्या होगा स्पाइनल एनेस्थीसिया में? It is bupivacaine. It is what, guys? Bupivacaine. And it is the most cardiotoxic also. Bupivacaine is the most cardiotoxic also. But why are you giving bupivacaine when it is most cardiotoxic? Why are you giving in spinal anesthesia as most common? Why? Because remember, bupivacaine will produce cardiotoxicity when you give the drug not in the CSF and inside the blood vessel. Okay, spinal mein you are giving bupivacaine in the CSF. Next, so if remember, your local anesthetic will add for some time only. If you want to increase the duration of your local anesthetic, you need to add something. What you need to add, guys? You need to add a drug which is called as additive. In additive, you are having many drugs. Adrenaline is there, sodium bicarbonate is there, but most commonly used additive drugs are opioids. In opioids, you are using many opioids, fentanyl, alfentanil, sufentanil. But the opioid that is not being used is remifentanil. Remifentanil is usually avoided in spinal anesthesias as it contains neurotoxic preservative. Hence, remifentanil is not used for spinal anesthesia. Now, as you are using opioid, what is the common side effect of this opioid? Opioids are not, first of all, good effect is what? They are increasing the duration of local anesthetic. But the side effect that comes with opioid is what? The most common side effect is patient might have pruritus. That is very, very important. That is, apart from that, patient might have vomiting, nausea, and respiratory depression also. Okay. Next, now you also need to remember sometimes after giving local anesthetic, patient will tell Doctor Saab, I'm having some itching, I'm having some rashes. Okay? What does it mean? Yani that local anesthetic has caused some allergic reaction. Now, which local anesthetic will cause allergic reaction? It is always the amino esters that will cause allergic reaction. Okay? Why? Because amino esters get metabolized to a compound called as PABA. PABA is para-amino benzoic acid. Now, if someone is asking you which amino esters will cause allergic reaction, always your concentration should be on PABA. PABA spelling is PABA. P and B. Concentrate on this. Why? Why? Because the local anesthetic starting with the alphabet P and B will cause allergic reaction. Okay? So, amino esters starting with P and B, amino esters. Okay? P stands for procaine. B stands for benzocaine. Okay. So this regarding what, guys? This is regarding the local anesthetics. Now, select the pair of local anesthetic which is regarded as the longest acting and which is regarded as the most cardiotoxic local anesthetic. Come on, guys. What's the answer for this? Come on. Longest to shortest acting local anesthetic over here. Right. There is a mnemonic to remember, guys. Longest to shortest acting local anesthetic. The mnemonic is what? Delhi to Bombay loves Priyanka Chopra. Okay? Delhi to Bombay. D stands for what, guys? D stands for dibucaine, which is regarded as the longest, but it is also regarded as the most toxic. Hence, we are not using this for anesthesia purpose. We are using dibucaine for some other purpose. That is basically for testing the pseudocholinesterase deficiency. Okay? T stands for tetracaine. B stands for bupivacaine. Okay? Remember, most longest is dibucaine. Next after dibucaine is tetracaine. Next, bupivacaine. Next, lignocaine. Shorter than bupivacaine is lignocaine. Shorter than lignocaine is procaine. Shorter than procaine is chlorprocaine. Remember, procaine is regarded as the safest local anesthetic to be used in a condition called as malignant hyperthermia. Now, guys, remember, bupivacaine, I told you it is most commonly used in spinal anesthesia as well as it is the most cardiotoxic local anesthetic. Okay? So, that's regarding what? Bupivacaine. That's regarding the longest to shortest. Okay. Now, regarding lignocaine, guys, 2 or 3 things have to be remembered. Lignocaine is most commonly used local anesthetic. Now, if you want to remember some points of lignocaine, with the spelling of lignocaine, you can remember. Spelling stands with LIG. L stands for what, guys? L stands for, it is the most commonly used local anesthetic worldwide. L stands for local anesthetic, most commonly used worldwide. Second most commonly used local anesthetic in spinal anesthesia after bupivacaine. Okay. Next, I stands for what? Lignocaine is the most commonly used local anesthetic in IVRA. IVRA is intravenous regional anesthesia, also called as Bayer's block. G stands for what, guys? G stands for garam. Garam means what? Garam means what? Lignocaine is the local anesthetic that can cause garmi to the patient. Garmi means what? Garmi is nothing but temperature. Yani it can cause hyperthermia. Which hyperthermia am I talking about? Malignant hyperthermia. So lignocaine, you have to remember this points. Okay? Now, what is the dose of plain lignocaine? When you are giving plain lignocaine, you have to give in a dose of 4.5 mg per kg body weight. But when you are mixing with adrenaline, you can give 7 mg per kg body weight. But if you exceed the dose, the patient will land up into toxicity. Obviously, the first line of toxicity, the first sign of toxicity appears in the CNS. And the first sign is what, guys? It is the perioral numbness. Perioral numbness followed by tremors, followed by seizures, followed by respiratory or cardiac arrest also. Okay, but the first sign is this one. Okay, if bupivacaine causes toxicity, remember guys, bupivacaine is the most cardiotoxic. If it will cause toxicity, first it will produce arrhythmias. If you see arrhythmias caused by bupivacaine, the drug that you give over here is amiodarone. If you see what? Arrhythmias. Okay, but the treatment of choice for bupivacaine or any local anesthetic toxicity is what? It remains 20% intralipid solution. 20% intralipid solution. Right? Next, I was telling you about IVRA, guys. IVRA is what? IVRA is Bayer's block. It's very simple, guys. If a patient is posted for fracture or something, fracture of the radius or something, what you need to do is, instead of making the patient fully unconscious, you just have to make this part numb. For making this part numb, you apply a tonic way over here. You give a local anesthetic so that this local anesthetic is only blocking this part. That is called as a Bayer's block. This tonic way which you are applying now, you apply with some pressure so that the local anesthetic don't go up. What is the pressure of tonic way? When you are doing upper limb surgery, it should be 50 plus systolic. 50 plus systolic BP. If it is a lower limb surgery and you are going for base block of the lower limb, then it should be 100 plus systolic. Why? Because remember guys, lower limb, the muscle mass is more and you have to apply more pressure. What is the drug commonly given in IVRA? Lignocaine. Lignocaine is most common local anesthetic to be given in IVRA. Which is the drug never given in IVRA? IVRA, it is always bupivacaine. Why? Because it's the most cardiotoxic. It is the most cardiotoxic. Okay. Next, guys. A 6-month-old child receives prilocaine for local infiltration. After some time, he develops cyanosis. Okay, due to unresponsive to oxygen therapy. What is the most likely cause of it? Now guys, what should be the answer for this patient? Okay, the patient has been received this local anesthetic called as prilocaine, and then he is not responding to oxygen. He became cyanosed. Remember guys, it cannot be aspiration pneumonia. Why? Because if it is aspiration pneumonia, patient will respond to oxygen therapy. Patient will have respiratory distress, but he will respond to oxygen therapy. Bronchospasm, if at all it is there also, still he will respond to oxygen therapy. Pulmonary embolism is very rare in children and infants. So again, it cannot be, but again, if it is there also, it will respond. What is the thing which is not responding? Methemoglobinemia. First, we need to understand why is the need of giving prilocaine to the patient. Apart from this question, prilocaine in children, normally it is given for what? If a child is there who's coming for you want to put an IV cannula, he's not allowing you to put IV cannula, you apply a cream called as EMLA cream. Okay? EMLA is nothing but eutectic mixture of local anesthetic where you give two things together, lignocaine plus prilocaine together. Okay? 2.5%. When you apply this cream, it is always stated on the EMLA pack also. It should not be given to neonates and avoid it in infants also. Why? Because lignocaine is not problematic. The problematic thing is prilocaine. When you give prilocaine to neonates, it gets absorbed. It gets metabolized to a compound called as toluidine. Okay? And what does this compound do? This compound oxidizes the ferrous form of hemoglobin. Ferrous form is a very good form of hemoglobin that carries oxygen. it oxidizes ferrous form to the ferric form that is not carrying any oxygen, and tissues become deprived of oxygen. Okay, that's why due to this reason it is avoided. If at all the patient develops this condition is called as methemoglobinemia. Okay, if the patient develops methemoglobinemia, the treatment of choice is what, guys? IV methylene blue. IV methylene blue should be given. Okay. Next. Acha, 50 plus systolic means what? 50 यानी के systolic blood pressure is 120. 120 plus 50 is 170. That is the pressure of tourniquet that you keep for the upper limb. Lower limb 100 plus systolic means systolic is 120 and you add more 100, that becomes 220 while keeping the tourniquet. That's the tourniquet pressure. Okay. Okay, guys. Next. Next is regarding the oxygen delivery devices. Come on, guys, just answer this question. Which oxygen delivery devices can deliver highest FiO2 in a non-intubated patient? Very good. Remember, if we are discussing about oxygen delivery devices, all should come in line, guys. Okay. Now, what should come in line? First of all, remember for answering this also, what we need to remember is a patient coming to the emergency when he is desaturating the first. He is stable, but still he is not maintaining the saturation. The first thing that I tell to sister is what? Put a nasal cannula. The first thing is nasal cannula. If his oxygen saturation does not improve, I tell her to switch to the face mask. Okay, that should be in line. Then if after face mask also if doesn't improve, then I tell the sister to put an NRBM, that is non-rebreathing mask. If still not improving, then I go for the fourth thing that is called as Venturi mask. If doesn't improve, then I tell the sister to go for high flow nasal cannula. Now guys, remember over here what he is asking, for answering this, first we need to remember all this in line. When I am telling the sister to put a nasal cannula, how much is the flow rate that she'll be keeping? 1 to 6 liters. That is the limitation of nasal cannula, and it will deliver an FiO2 of 25 to 45%. That's the limitation. If still not improving, I tell please go for face mask. That will deliver 6 to 10 liters of that's a flow rate of 6 to 10 liters, and it will deliver an oxygen of 35 to 65%. If still not improving, NRBM will deliver NRBM will deliver 10 to 15 liters, which will achieve an FiO2 of 95%. If still not improving, Venturi mask, what is the flow rate, guys? 2 to 15 liters, FiO2 is 24 to 60%, and HFNC is 40 to 60 liters of flow rate, which gives an FiO2 of 100%. So he's asking you about what, which is the oxygen delivery device which is having an FiO2 of close to 100%. Now over here, nasal cannula is 25 to 45%. Okay, simple face mask is 35 to 65%. NRBM is how much, guys? 95%. Close to 100 is NRBM. Venturi is also 24 to 60%. Is it clear, guys? Next, AMBU. Now guys, AMBU is artificial manual breathing unit which can deliver 100% of oxygen. In this AMBU, you are having a valve. Two valves are there. One is called as Rubin's valve, which is a unidirectional valve that prevents rebreathing. Other is a pressure remitting or pressure relieving valve that is commonly seen in the pediatrics to prevent barotrauma. Okay, that relieves the pressure at 30 to 40 centimeters of water. Okay. That is regarding AMBU. We are having adult AMBU and pediatric AMBU. Next, a patient with moderate hypoxemia is receiving oxygen via nasal cannula at 3 liters per minute. What is the approximate FiO2 delivered? Now guys, what's the answer for this? Come on, A, B, C, D. For answering this, always you need to remember every 1 liter of oxygen given to the patient, it increases the FiO2 by 4%. 2 liters, 8%. Here in the question, it is 3 liters. 3 liters into 4 is equals to 12% of FiO2. But if you look at the option, there is no 12 given in the option. 24, 32, 40 and 60. But you have to just mix some logic over here. He's not given the atmospheric oxygen. Atmospheric oxygen will be always 21%. At 21 plus 12, that is equals to 33%. The closest to 33 is 32%. So option B is the right answer over here. Okay. Okay. Chalo. Next. A patient on mechanical ventilator develops muscle atrophy. Now, which mode of mechanical ventilator attribute towards this complication? Patient was on mechanical ventilator, develops muscle atrophy. Now guys, remember there are many modes of mechanical ventilators, but on which mode will patient develop this muscle atrophy? Obviously on the mode that is taking control of the patient's volume as well as the pressure. Come on guys, which is that mode? Pressure support is a weaning mode, not there. Okay? SIMV is a weaning mode. BiPAP is basically a non-invasive mode. Okay? Again, it cannot be there. Okay? BiPAP can also be used for weaning. What is the mode that takes control of the patient's total breathing? It is the CMV mode. CMV mode. In CMV mode, patient is basically CMV mode will tell the patient like this. CMV mode will tell the patient kabhi kabhi lagta hai apuni bhagwan hai yani ke why because in CMV mode, remember ventilator, there are two things guys for mechanical ventilation. One is the volume, other is the pressure. CMV mode takes control of both the things, volume as well as pressure. He'll tell the patient to relax. You just be relaxed. CMV mode tell the patient to be relaxed. You just be sedated. And what will happen if the patient relaxes and all? Patient develops the habit of becoming relaxed. He don't use his respiratory muscles and he'll develop atrophy of the muscles. Okay. So guys, before going towards the CMV mode, first we need to go for ventilators. In ventilators, guys, there are two kinds of mode. There are two kinds of ventilators. One is non-invasive, other is invasive ventilator. Just look over here, guys. Non-invasive meaning what? You are not invading and going inside the trachea. You're just giving the ventilation through the mask. What is the prerequisite for non-invasive ventilator? Patient should be conscious and patient should be empty stomach. Then only non-invasive ventilator will work. There are two modes in non-invasive. One is CPAP, other is BiPAP, continuous and by pressure. By pressure means what? Inspiratory and expiratory. BiPAP means it will produce a higher inspiratory and a lower expiratory pressure. Both are used in COPD patients. BiPAP is used in a patient who is having severe COPD. That is regarding the non-invasive mode. If the patient is not improving on the non-invasive mode, you go for the invasive mode of ventilator. In the invasive mode of ventilator, guys, what are the modes that we are having? We are having the big boss mode, or I showed you the picture, na? CMV mode, okay? Continuous mandatory ventilation. We are having the assist control. As the patient is improving, you can go for assist control. In that, you are having volume control and pressure control. And we are having the spontaneous modes. Now, guys, what we need to remember in these modes are, we need to remember the control variable. And we need to remember, is trigger breathing allowed or not? And we need to remember how much is the sedation and last is the side effect. Now, if you are going with the CMB mode, which is a control variable, you are not controlling anything. Ventilator is the thing that is controlling the pressure as well as tidal volume. So, there is no control variable. Whereas, triggered breathing, are you allowing any triggered breathing? Strictly no. CMV यानी के what? He will think that I am the big boss. मैं ही भगवान हूँ, मैं ही control करूँगा सब. ठीक है? So, but this mode requires the patient to be heavily sedated. And due to the CMV mode, what will happen, guys? Patient will develop muscle atrophy. Normally, if the patient, this mode, this kind of mode is the initial mode of ventilator. Whenever the patient is coming, he revives a cardiac arrest or a major road traffic accident, we go with CMV mode. Once the patient is improving on CMV mode, then we give a trial of ACMV. ACMV is the most common mode of mechanical ventilator. Again, in ACMV mode, what is the control variable? Yani ke in ACMV, there are two modes, guys. Volume control and pressure control. If I am setting the tidal volume 400, tidal volume 500, I am keeping on the tidal volume and I am setting it, then it is called as volume control. In the control variable in volume control is the tidal volume, which is set by the anesthetist or the doctor. What the ventilator does, ventilator has to just change the pressure and deliver to the patient. Okay, is trigger breathing allowed in ACMV mode? Yes. some trigger breaths are allowed. Then only we'll come to know a patient is improving or not. Sedation, how is the sedation compared to CMV? In ACMV, you have to moderately sedate the patient as the patient is improving. But guys, as we are allowing some triggered breathing in the volume control mode, what will happen, guys? Remember, as our ventilator is giving some breath, okay, and next breath is taken up by the patient. Next again, ventilator is giving breath and next breath is taken by the patient. Is the ventilator and patient breath both equal? This is the ventilator breath, this is the patient breath. Both are not equal. So what will develop, guys? Due to this, asynchrony will develop. The respiratory rate might increase. Due to that, the most common side effect of this mode is what? Patient might develop respiratory alkalosis in volume control mode. Okay, usually volume control is usually given for a person who's having a normal lung mechanics. But what if the patient is having ARDS where the compliance of the patient is low? Then you go for a pressure control mode. In the pressure control mode, what is the control variable? That is important. Control variable means what I am controlling. I will set a pressure. So the control variable is pressure. Ventilator will basically change the volume and it will deliver the volume. Is trigger breathing allowed? Yes, somewhat it is allowed. How is the sedation over here? Moderate sedation might be required over here. Okay, now in pressure control mode, what can happen, guys? As we are setting the pressure, ventilator sometimes might be generating the adequate volume, sometimes might be giving a low volume. Okay, due to, and most of the times, if it is generating a good volume, no problem. But most of the time in pressure control, the ventilator is not able to meet the patient's tidal volume as it has to generate itself. The patient will develop hypoventilation and might develop respiratory acidosis. Guys, remember, most of the modes of ventilator will develop a complication of respiratory acidosis except the volume control mode that has respiratory alkalosis as a complication. Okay. Next, if the patient is improving on pressure control mode, then we go for spontaneous mode. In spontaneous, we are having SIMV and pressure support mode. SIMV mode, remember guys, SIMV mode means what? In SIMV mode, ventilator is delivering a good amount of breath to the patient and then again patient is taking a small breath. Okay? SIMV means what? We are giving chance to the patient that he has to breathe and all. There is no control variable over here in SIMV mode. Trigger breathing means yes, you are totally allowing trigger breathing. How is the sedation? Very low sedation is required in SIMV mode, okay, or no sedation is required in SIMV mode. Okay, but over here also what is happening now in SIMV mode? Two things can happen, guys. Okay, SIMV mode, patient can develop respiratory alkalosis also, respiratory acidosis also, depending upon how the patient is. Sometimes patient is improving well. Then what will happen if the patient is improving well? Then what will happen in SIMV mode? We are delivering a breath. Patient is also taking a breath which is very much equal. Then we are delivering a breath. And again patient is taking a breath. So the patient respiratory rate is higher and he will develop a high carbon dioxide is washed off and respiratory alkalosis can happen. But if the patient muscles are still weak and we are giving an SIMV mode trial, then what will happen? Patient might develop hypoventilation or respiratory acidosis. Hypoventilation or respiratory acidosis can also happen in spontaneous modes. Okay. So once again, pressure control. देखो, pressure control mode is usually used for ARDS patient where the compliance is low. Okay. What is the control variable? Pressure. What is the trigger breathing allowed? Yes, trigger breathing is allowed and sedation moderately required. Now in pressure control mode, as we are setting a pressure, volume can be changed and ventilator sometimes can normally what happens is 80% of the time ventilator is not able to generate the tidal volumes. Due to that, patient will become hypoventilated and develop respiratory acidosis. Okay. Chalo bhai, next. 60-year-old patient is on pressure control ventilation. He develops sudden hypotension after PEEP is increased from 5 to 15. Most likely cause of it. Come on guys, what's the answer for this? PEEP. First of all, PEEP hai kya bhai? PEEP is what? PEEP is nothing but positive end expiratory pressure. Okay. Why do you give this PEEP? Remember, whenever the patient's alveoli are totally exhausted, PEEP is a commando. PEEP is a commando from the ventilator that basically helps the lungs to recruit new alveoli. Whenever the alveoli collapses, PEEP is a kind of commando that will basically helps the lung to recruit new alveoli. That is recruitment maneuver. Okay? PEEPs help to recruit new alveoli are formed, and PEEP will prevent atelectasis also. Positive end expiratory pressure will prevent collapsing of other alveoli also. Now, but the side effect of PEEP is what? Remember, so you guys are giving answer as C, some are giving A. Just look over here, guys. What is happening? This patient who's being given PEEP, which was normally 5, it has increased to 12. What could happen? And he has developed what? Sudden hypotension. Now, guys, remember, it cannot be myocardial infarction. Why it cannot be myocardial infarction? If at all myocardial infarction was there, in the question they should mention chest. This both are not mentioned, so myocardial infarction is not there. It cannot be sudden airway resistance increased. Okay? If it is sudden airway resistance increase, it will not cause hypotension, guys. It will cause raised airway pressure. Airway pressures will be increased. Ventricular, if ventilator asynchrony is there, that won't cause sudden hypotension. That will cause gradual hypotension. The answer over here is PEEP. I have increased the PEEP from 5 to 12. That will cause hypotension. Now the question is, how, sir? Why will it cause hypotension? As you increase the PEEP, what is happening? The intrathoracic pressure increases. If intrathoracic pressure increases, cardiac output decreases. If cardiac output decreases, BP decreases. Due to this reason, we say never give PEEP for a patient who is in shock on mechanical ventilator. If the patient is in shock and he's on mechanical ventilator, don't give PEEP. Why? Because PEEP will worsen the hypotension over here, right? So guys, coming to the PEEP, what is PEEP? PEEP recreates the alveoli to improve oxygenation. PEEP is positive end expiratory pressure. PEEP improves oxygenation, prevents atelectasis, okay, and decreases the work of breathing. Usually PEEP is used for ARDS and pulmonary edema. But remember, guys, PEEP, what is it doing? If you give excess of PEEP, what will happen? Intrathoracic pressure increases. Sometimes excess of PEEP will also cause what? It will decrease the cerebral venous drainage. If cerebral venous drainage is decreased, what will happen to the intracranial pressure? Intracranial pressure increases. Hence, PEEP is contraindicated in head injury or in conditions where patient's intracranial pressure is already high. You never give PEEP. That is positive end expiratory pressure. Okay. Normal PEEP you said is between 5 to 24 depending upon the FiO2 that you are setting. Is this thing clear? Okay. Now look over here, guys. Coming to the next question. A patient with head injury is on mechanical ventilator. Targeted PaCO2 is 30 to 35 mm of Hg for ICP control. Which ventilator adjustment is most appropriate? Okay, guys. So remember, this patient is having an intracranial pressure which is high, right? And we have to target the PaCO2 of 30 to 35. What we need to do? If I increase the FiO2, will it decrease the PaCO2? No. It will just improve the oxygen, but it won't decrease the carbon dioxide. PaCO2 won't be decreased. Okay? If I increase the PEEP, is it good for intracranial pressure control? Never. I told you just now. If I increase the PEEP, what will happen? Cerebral venous drainage will decrease and ICP will increase. So this cannot be done. That cannot be done. Now what are we left out with? Increasing the respiratory rate or decreasing the respiratory rate? Guys, remember, if I increase the respiratory rate, what will happen? If I increase the respiratory rate, it will cause cerebral vasoconstriction. If cerebral vasoconstriction happens, what will happen to the cerebral blood flow? It decreases. If cerebral blood flow is decreasing, what happens to the ICP? It decreases. So I need to increase the respiratory rate. If I decrease the respiratory rate, obviously ICP would be increased and all. Okay. So in order to maintain the PaCO2 of this thing and control the ICP, what is the setting that we need to do? Increase the respiratory rate. Okay. Next, guys, on the ventilator, on the mechanical ventilator, there are some values that we need to remember, and there are some conditions. Depending on the conditions, you can change or you can vary the values. So normal respiratory rate, how much you set as 12 to 18. What is the tidal volume? Normally you set as 6 to 8 ml per kg body weight. Okay. FiO2 normally you set 21 to 100% depending upon the patient's condition. PEEP you set as 5 to 24, maximum of 24. Okay. PEEP plateau pressures are there which should be less than 25. Then there is I is to E ratio, that is inspiratory to expiratory ratio, that is 1 is to 2 or 1 is to 3. But in the case of ARDS, we reverse this ratio and make it as 2 is to 1 or 3 is to 1. In ARDS, we also go for prone position ventilation where 16 to 18 hours of prone position is there and 4 hours of supine positioning is given. Anyways, guys, this is the normal values. If the patient is having respiratory acidosis where carbon dioxide is more, I need to wash out carbon dioxide. What you need to do? I will increase the respiratory rate. I'll increase the respiratory rate. Okay, if respiratory acidosis, what is the change that you do in the ventilator setting? Increase the respiratory rate. If the patient is having ARDS, remember guys, ARDS, already the lung is in a bad state. You don't want to overinflate the lung by giving a high tidal volume. Give a lung protective strategy. Go for a lung protective strategy. You go for 4 to 6 ml per kg body weight. Tidal volume. Okay. Next, FiO2. FiO2 depends on 21, depends on the patient, 21 to 100%. Okay. Next, PEEP. PEEP 5 to 24 you are giving, and it basically helps in preventing hypoxia. Whenever the patient is having hypoxia, you add PEEP to the patient. Now guys, remember PEEP, how much of PEEP you are giving, it depends upon how much FiO2 you are adjusting. Okay, that's regarding the normal values. Okay, is this thing clear? Yes or no? Come on guys, please give me a thumbs up. If things are clear, please give me a thumbs up. Before answering this, just give me a thumbs up, guys. No one is giving thumbs up. And again, it's not clear. Okay. Okay, a 60-year-old male with ischemic heart disease is scheduled for hernia repair. Which IV induction agent is safest? So guys, remember, IV induction agent safely that could be given over here is what? I can never give propofol in this patient. Why? Because ischemic heart disease patient cannot tolerate hypotension, cannot tolerate hypertension, cannot tolerate bradycardia, cannot tolerate tachycardia. Okay? They cannot tolerate these things. Okay? Propofol, what does it cause? It causes hypotension and it can cause bradycardia, so it cannot be given. Can you give sodium thiopentone? Sodium thiopentone also causes hypotension and thiopentone T, tachycardia T. So it will cause tachycardia, so it cannot be given. Can you give ketamine? No, sir. Why? Because it causes hypertension and tachycardia. Can you give ethomidate? Yes, sir. Why? Because ethomidate is the thing that maintains the BP and maintains the pulse rate. It is a cardiostable IV induction agent. Okay. So guys, just a second over here. So look over here. If at all I am increasing the respiratory rate, what will it do? If I increase the respiratory rate, basically it will cause cerebral vasoconstriction, and that cerebral vasoconstriction will decrease the cerebral blood flow, and hence ICP will be decreased. Okay? Is it clear? Sure. PEEP is used in ARDS patient. Yes, because in ARDS patient the oxygenation is low, na? So ethomidate. Before going to ethomidate, guys, first of all, we need to have a brief introduction of IV induction agents. IV induction, in general anesthesia, if you want to make the patient unconscious, you can give an IV induction. You can make by giving IV, okay? Or you can go for inhalational induction. But 99% only IV induction is given. In IV induction, again, guys, remember there are two types of IV induction. One is non-opioid, other is opioid. Opioid kind of IV induction is given for patients who is having low ejection fraction. Okay, and non-opioid is given for 98% of the patients who are having a good heart. And in non-opioid, what are the IV induction agents? Thiopentone, propofol, ethomidate, and ketamine. Thiopentone, propofol, ethomidate usually acts through the GABA receptor, whereas ketamine acts through the NMDA receptor. Apart from ketamine, xenon and nitrous also act through the NMDA receptor. Okay. Now guys, as we are discussing about ethomidate. Ethomidate is the most cardiostable. Sorry, ethomidate is the most cardiostable IV induction agent. Whenever, but remember one thing, whenever you give ethomidate as a long-term infusion, what could be happening, guys? Patient is at a risk of developing adrenal suppression. Okay? There is one more IV induction agent which is called as methohexitol. Methohexitol is commonly used for ECT. ECT is what, guys? Electroconvulsive therapy. Okay. Next, a 30-year-old patient is posted for lipoma excision on hand under general anesthesia in a daycare setup. Daycare बोलते ही एक दो ड्रग्स मेरे माइंड में आ गए हैं, ठीक है. Anesthetic plans for TIVA. TIVA is total intravenous anesthesia. Which IV induction agent should be used? Three clues are given. TIVA, Daycare, ठीक है. 2 clues are given. So guys, what's the answer? Very good, very good. Daycare anesthesia, always remember propofol. First, the most common reason is what? The elimination T half of propofol is less than 2 hours. That's why we are giving propofol in daycare anesthesia. Now guys, remember, propofol is used for, first of all, some introduction for propofol. Propofol is a milky white solution, but it is made up of egg lecithin and soy. Egg lecithin acts as an emulsifying agent over here. It acts as a emulsifying agent or emulsifier over here. Whenever you open the propofol vial, it should be used within 6 hours. Otherwise, it easily gets contaminated by bacteria. Okay? Remember, propofol is the most painful IV induction agent. Now, the most important thing for propofol is what, guys? Propofol is an IV induction agent of choice for daycare anesthesia. Now, everyone look over here. Daycare anesthesia. With this daycare anesthesia, all MCQs related to propofol, it's my responsibility to make you learn this. Remember, for daycare anesthesia, okay, whenever the patient is posted for daycare surgery, will you put an ET tube or will you put an LMA? Will you put an ET tube or LMA? First answer this, guys. If you put an ET tube, patient might complain of sore throat and all. You will put what, guys? Come on. You'll put what? So there is some lag, please. ET tube or LMA? LMA, very good. So you will put an LMA. Apart from that, remember, guys, if a patient is posted for daycare anesthesia, will you give all complicated forms of anesthetic drugs? No. You can go only with a single shot that is called as TIVA, that is total intravenous anesthesia. IV anesthesia you are giving without inhalational agents. Okay. Next, in daycare anesthesia, you want to give the drug that has no problem to the patient. No problem means what? It should be having some anti-emetic properties and anti-pruritic properties. Anti-emetic as well as anti-pruritic properties. And this drug which you are giving for daycare anesthesia, it should be free from side effects like what? Free from side effects like malignant hyperthermia or acute intermittent porphyria, or it should not cause any liver disorder. So basically remember, guys, propofol is an IV induction agent. Yes. Sorry guys, पता नहीं क्यों stuck हुआ. Now, am I audible? Yes, बोल दो भाई. आवाज आ रही है? Yes, चलो. Right. So guys, remember ketamine we were discussing, right? Ketamine is an IV induction agent of choice in shock. Now, regarding ketamine, what we need to remember is ketamine is a complete anesthetic agent which is an NMDA receptor blocker. NMDA receptor blocker. Okay? So basically, we have to remember ketamine is a phencyclidine derivative, which is an NMDA receptor blocker. There is one drug called as S-ketamine, guys, which is a psychoactive active drug which works as a rapid acting antidepressant. Okay, this was asked also recently. S-ketamine, it is given at a very subminimal dose, guys. 24 to 30 milligrams intranasally you give, which acts as a rapid acting antidepressant. Now, guys, regarding ketamine, अच्छा प्रोपोफॉल पे ही मैं डिस्कस कर रहा था. Okay. If at all I was discussing with propofol, just look over here, guys. Next question was, young male who is in trauma has hypotension and tachycardia. Which is the IV induction agent that could be best used? Remember, hypotension, tachycardia means patient is in shock. In shock-like conditions, you cannot give propofol. Shock यानी कि patient is having a BP of 70/40. If you give propofol, it will cause hypo and propofol. We have completely discussed propofol, or we were discussing propofol only? I think we have discussed propofol completely, right? Guys, was propofol clear? This slide of propofol at the mid. Okay. If it was at the mid, guys, we'll just start from here. I'll just give you a brief. Remember, propofol is regarded as an IV induction agent of choice for daycare surgery. When I am talking about daycare surgery, all the points of propofol, all the MCQ points of propofol are related to daycare surgery. In daycare surgery, you will put LMA. In daycare surgery, you will go for TIVA. TIVA is not called as total intravenous anesthesia. IV giving general anesthesia with IV agents without inhalational is called as TIVA. Okay? Remember, for a daycare surgery patient, you need to give a drug that is having antiemetic as well as antipruritic property. That is propofol. In daycare surgery, you need to give a drug that could be safely given or that is having no contraindications to these things like malignant hyperthermia or acute intermittent porphyria or liver disease. Yani basically, it should not have any problems that it can cause malignant hyperthermia or acute intermittent porphyria or liver disease. So IV induction agent of choice for daycare surgery is propofol, and in daycare surgery, all these points will be covered. Propofol is IV induction agent of choice for all these things. LMA insertion, TIVA, antiemetic, antipruritic, malignant hyperthermia, acute intermittent porphyria, and liver disorder. Okay. Now starting with this question, a young male in trauma has hypotension and tachycardia. Which IV induction agent is best? Right. Propofol, thiopentone, ethomidate, ketamine. Remember, guys, this patient is in shock. You won't give propofol. Propofol will cause hypo and brady, so you won't give it. Thiopentone will cause hypo and tachycardia. Okay? Hypotension and tachycardia, you won't give it. Ethomidate will maintain the BP of 70/40, you won't give it. The only drug that could be safely given over here is what, guys? Ketamine. Why? Because ketamine, in shock-like conditions, you want to increase the BP. So, ketamine is that drug. Ketamine is basically a complete anesthetic agent. It is a phencyclidine derivative, acts as an NMDA receptor blocker. I told you about the point of S-ketamine also. Now, guys, some points of ketamine that you need to remember regarding ketamine is, what is the effect of ketamine on various systems? When I am talking about various systems, always remember I am talking about the CNS, I am talking about the respiratory, cardiovascular, muscle and other systems. So remember, guys, ketamine, whenever you give to the patient will have a pat se headshot. You know this? In PUBG, there was this PUBG meme, right? I think this guy name is, I don't know. Anyone who knows? Pat se headshot. Who used to tell? Arey kuch tha bhai. When I used to play PUBG, I used to Dynamo, right, Dynamo. Okay. So anyways, so ketamine, when you give to the patient, it will cause pat se headshot to the CNS. Okay. It is the worst enemy of CNS and it is the best friend of all other systems. As it is a worst enemy, what will it do, guys? Ketamine increases the ICP, IOP. If it is increasing the ICP, it will be contraindicated in head injury and neurosurgery. Head injury and neurosurgery. Ketamine increases the IOP, hence it is contraindicated in glaucoma. Ketamine causes epilepsy, hence contraindicated in epileptic patients. Okay? Ketamine causes hallucinations. After giving ketamine, as the patient is recovering, patient will tell this kind of features. Doctor, it seems I was flying. Doctor, I feel like flying. I am feeling this. I am feeling that. That is called as hallucinations. So ketamine is as ketamine causes hallucination, it is contraindicated in patients who are having schizophrenia. Okay, so ketamine, these are the side effects. If all ketamine causes hallucination, some of those hallucinations can be easily managed by a drug called as midazolam. Okay, so ketamine effect is, it is the worst enemy of CNS but best friend of all systems. All system means what? It is a best friend of respiratory, hence ketamine causes bronchodilation. It causes bronchodilation, hence it is the IV induction agent of choice for patient who's having asthma. Apart from that, cardiovascular, ketamine is the best friend. Remember, ketamine is the worst enemy of CNS, friend of all systems. If it is friend of all systems, cardiovascular is also coming under all system. So it is a best friend. So what will it do, guys? Ketamine increases the BP and pulse rate. Hence, you can give ketamine in shock. It is IV induction agent of choice in shock as well as cyanotic heart disease such as tetralogy of Fallot. Okay, but it is avoided in ischemic heart disease and all. Okay. Next, ketamine increases the muscle tone. That's regarding what, guys? That's regarding the ketamine. Next, coming to the other question. 26-year-old patient who is posted for open reduction internal fixation of the right radius under GA. He is known case of bronchial asthma on regular medication. Which IV induction agent should be avoided? Before avoided, guys, tell me which IV induction agent should be given in this patient. IV induction agent of choice in asthma which causes bronchodilation. It is always ketamine. Ketamine should be given. Which should be avoided, guys? Come on, which should be avoided? ABCD, what's the answer? Which should be avoided, he is asking. Avoided is thiopentone. Why? Because thiopentone releases histamine, can cause bronchoconstriction. As we are discussing thio, we'll discuss some points of thiopentone. Thiopentone is what, guys? Thiopentone is available as a yellow amorphous powder. It is regarded as ultra short acting barbiturate. Why? Why? Because whenever you give thiopentone, it gets rapidly redistributed due to its rapid redistribution, where into the fat and fat or adipose tissue or the muscle it gets redistributed. Due to that, it is called as ultra short acting. It has some anti-thyroid property and it is always available as a powder form. You need to make it as a solution by adding normal saline and all, but never add Ringer's lactate. Why? Because it can form crystals. Okay. Now regarding thiopentone and ketamine are always opposite. Guys, remember, one line of ketamine, all MCQs solved. What was the one line? Enemy of CNS, friend of other system. Thiopentone, opposite of ketamine. It is the best friend of CNS, enemy of other systems. Best friend of CNS, enemy of other system. When I am telling best friend of CNS, it basically decreases the intracranial pressure, can be given as IV induction agent of choice for head injury and neurosurgery. Okay? It is having anti-epileptic properties, so it can be given in epileptic patients. It can be used for narco analysis. For truth test, you can use this. Okay? Narco analysis. But it is contraindicated in what? Contraindications usually come from the enemies. Enemies are all other systems. So it is contraindicated in asthma. Why? Because it causes bronchoconstriction. Okay, guys? So this is regarding what? Thiopentone. Next. A 10-year-old boy with Duchenne's muscular dystrophy develops cardiac arrest after receiving succinylcholine. What is the likely cause of it? Come on, guys, after receiving succinylcholine, the patient develops cardiac arrest. What's the reason? Remember, whenever you give succinylcholine to the patient, it produces a side effect. What side effect? It increases the potassium. Okay? In normal patients only. If the patient is already hyperkalemic means what? Patient having muscular dystrophies, their potassium levels are already high. So imagine this patient's potassium level was 7. You give succinylcholine to this patient and his potassium becomes 9. Patient will develop what? Arrhythmias that can lead to cardiac arrest. So over here, the answer is what, guys? Hyperkalemia. Hyperkalemia. So regarding succinylcholine is regarded as the shortest and the fastest acting muscle relaxant. Why it is regarded as the shortest acting? Why? Because it acts for a short duration of 3 to 8 minutes. And what? Why it is regarded as the fastest? Why? Because the onset is 30 to 45 seconds, the patient muscles will relax. But remember, guys, as you give scoline to the patient, first muscles will contract, then relax. Okay, as muscles are contracting, this contraction of the muscle in the initial phase of succinylcholine will cause hyperkalemia and all. Where is succinylcholine metabolized, guys? It is metabolized by pseudocholinesterase. Pseudocholinesterase. But if the patient is having pseudocholinesterase deficiency, then the patient can land up into a condition called as choline apnea. Choline apnea. If the patient is having pseudocholinesterase deficiency, he might land up into choline apnea. Yani ki you have given scoline. After scoline, giving scoline, patient should recover in 8 minutes. If he is not recovering, that means choline apnea. What you should do, you should go for a test for diagnosing it that is called as Daybucane number test. Now remember, guys, you might have remembered Daybucane is the longest acting local anesthetic, not used for anesthesia purpose, only used for diagnosing this choline apnea. Yani ki imagine, guys, you have given scoline. In 8 minutes, patient had to recover. You waited for 20-25 minutes, patient is not breathing at all. You are ventilating the patient. What is the management? Will you stop the ventilation? No. The best management of choline apnea is what? You ventilate the patient. Yani ki positive pressure ventilation till the patient recovers. Normally 2 to 3 hours, the patient will recover. Okay? Now, what is the most common side effect of using scoline? The most common side effect, as you give scoline, I told you, patient will have contractions. So, patient, due to this rapid contraction, in the post-op period, remember, contraction was happening in the intra-op time. In the post-op period, when you go to the patient, patient will complain of muscle soreness. That is the most common complication of scoline. Okay, post-op myalgia, very good. Okay, second common is what? Hyperkalemia. It increases the potassium by 0.5 to 1 milliequivalent per liter. Okay, so that is the common side effect of scoline. Next, 40-year-old cirrhotic patient requires muscle relaxation for surgery. Which which muscle relaxant is safest in this patient? Come on, guys. Which muscle relaxant can be safely given over here? If the patient is having cirrhosis of the liver is the problem, you need to give a drug that bypasses the liver. Is there any muscle relaxant that bypasses the liver or undergoes magical metabolism called as Hoffman degradation? That is only one muscle relaxant. Not one, two muscle relaxant. But over here, only one is given. That is called as atracurium. Remember, atrac and cis-atracurium undergoes Hoffman degradation, bypasses the liver, can be safely given in cirrhotic patients. Okay, so guys, now as we are discussing muscle relaxant, we'll discuss something about muscle relaxant. Muscle relaxants are the drugs which are categorized into non-depolarizing and depolarizing muscle relaxant. In depolarizing, you are having one, that is succinylcholine. In non-depolarizing muscle relaxant, you are having again two categories. One is called as benzyl isoquinolonium, other is called as aminosteroidal compounds. Benzyl isoquinoloniums, these are the drugs which are ending with the term curium, such as atracurium, cis-atracurium, mevacurium, doxacurium. Okay? Next, steroidal, what are the things? Curoniums, pancuronium, rocuronium, vecuronium. So guys, remember, once the muscle relaxant drugs came into the market, the first muscle relaxant that was used was D-tubocurare. But this was having some side effects. We are not using this drug. Okay? Instead of D-tubocurare, next came was benzyl isoquinolonium, which was the first one, atracurium. When atracurium came into the market, it was the best muscle relaxant, but two side effects of atracurium were commonly seen. What two side effects? Remember, guys, atrac and cis-atrac are always undergoing what metabolism? Hoffman degradation. Due to that, it bypasses the liver and all. Okay, but two side effects were seen. What two side effects? Atracurium was causing histamine release, and on long-term infusion of atracurium, the patient was landing up into a condition like patient was landing up into seizures. Why? Because atracurium was forming a compound called as laudonosine. Due to this reason, atracurium, they told we will not use atracurium. Then came the next muscle relaxant into the market, that is cis-atracurium. Cisatracurium, when it came into the market, it was regarded as the best muscle relaxant. Why? Because it was undergoing Hoffman degradation. Apart from that, it was having less side effects of atracurium. Less side effects compared to atracurium. Okay. Next came what? Mevacurium. Mevacurium is regarded as the shortest acting muscle relaxant. Shortest acting non-depolarizing muscle relaxant. Mevacurium. Next came doxycurium, which is regarded as the longest acting. Now guys, remember attract and cisatrac, Hoffman degradation, you have to remember. Meva and doxa, how you have to remember guys? For that, the mnemonic is my short dog has long tail. My means what? Mevacurium, which is the shortest acting muscle relaxant. Dog means what? Doxycurium, which is the longest acting muscle relaxant. Okay, that is done. But again, doxycurium is most toxic. That's why we are not using. Second longest is what guys? It is pancuronium. Pancuronium. After pancuronium, then came rocuronium and then came vecuronium. Now guys, regarding pancuronium, what we need to remember, pancuronium starts with an alphabet P. It is the second longest muscle relaxant, but it is having a side effect of RRR. RRR was the movie guys, which was a pan-India movie. So you have to remember, pancuronium means RRR will come. You have to remember RRR. Pancuronium means RRR. Why RRR? Remember, R means what guys? Renal. Pancuronium is having maximum renal excretion. Hence, it is contraindicated. Hence, it is contraindicated in renal failure. Contraindicated renal failure. Next, recovery. Pancuronium is having it is the second longest acting, hence it can cause delayed recovery. Last is what guys? Pancuronium increases the rate. What rate I am talking about? It increases the BP and pulse rate. Hence, it is a muscle relaxant of choice in shock. Muscle relaxant of choice in shock. IV induction agent of choice in shock was ketamine. Pancuronium is a muscle relaxant. Next is vecuronium. When we are discussing about vecuronium, always remember guys, vecuronium V looks like heart. Valentine's heart. Okay, vecuronium means heart only, you have to remember. Why? Because it is the most cardiostable muscle relaxant. Most cardiostable muscle relaxant. Most cardiostable IV induction was ethomidate, but it is having excretion through the biliary tract. It is having maximum biliary excretion. Hence, it is contraindicated if the patient is having obstructive jaundice. Don't give vecuronium. In obstructive jaundice, don't give vecuronium. Okay. Next is what is rocuronium. When we are talking about rocuronium, always remember rocuronium is RO. Okay. It is the rapid acting, rapid onset. Rapid onset means what? Rocuronium is the fastest acting muscle relaxant. It is the fastest acting muscle relaxant. Okay. Rocuronium, rapid onset. RO of rocuronium, rapid onset. Okay. Next guys. A 20-year-old child is undergoing tonsillectomy. Which agent is best for smooth inhalational induction? I used to remember rocuronium as a painful rock star also guys. Why? Because it is a painful muscle relaxant. On injection, it produces pain as well as it's a rock star. Very fast acting. Come on guys, what's the answer for it? For smooth inhalational induction. Come on guys, when he is telling inhalational induction, first you need to understand guys, induction meaning what? You are making the patient unconscious. You make the patient unconscious 99% by IV induction only. 1% you use inhalational. That too, those 1% will be always children. Okay? And whenever inhalational induction is given, only one drug should come to your mind. Two inhalational agents can be used guys. Civo and halo, but more better is what, or the best one is what? Sevoflurane. Why? Because it is having sweet odor. If Civo is not there, you can go for halothane. But Death and ISO, they are not at all given for induction. Okay? So remember, induction, smooth inhalational induction, what is the drug of choice? Okay. Mevacurium is the shortest guys, not the fastest. Fastest when you tell when it is having a onset fast. Okay, mevacurium is having a duration which is small. Okay, so Civo. When we are talking about Civo, remember guys, sevoflurane is used for what purposes? Sevoflurane is a special inhalational agent used for induction of anesthesia, but mainly it is used for what? All inhalational agents are mainly used for maintenance of anesthesia. Sevoflurane is the inhalational agent of choice in what, guys? Inhalational agent of choice in bronchial asthma. Why, guys, in bronchial asthma? Why? Because it is having what? Bronchodilation property. It is the inhalational agent of choice in children. Okay. Sivo means sweet. Sweet color of Sivo means, always remember, sweet sevaya. Sweet sevaya is Sivo. Sevaya color is yellow. Sivo is stored in yellow color vaporizer. Okay. So anyways, next, Sivo is the inhalational agent of choice for daycare surgery. Why, guys, in daycare surgery we use Sivo? Why? Because remember, Sivo is sweet in odor as well as it doesn't cause any problem. Previously, it used to be desflurane for daycare surgery, but desflurane causes laryngospasm and it causes some airway irritation. Hence, we are not using. Next, Sivo is the inhalational agent of choice for neurosurgeries. Previously, isoflurane was for neurosurgeries, but more good than iso is Sivo. Okay. ISO is the second best. It's not that ISO cannot be used. ISO is the second best. But sevoflurane should be avoided in renal patients. Why? Because sevoflurane, when you give in low flows, it will basically low flows, and when you give in a closed circuit, it will react with a soda lime. Remember, in closed circuit, there is a chamber that will absorb carbon dioxide. That sevoflurane will react with the soda lime. That chamber is called a soda lime chamber to form a toxic compound called as compound A or olefin, which is the nephrotoxic compound. Okay. Next, guys, regarding isoflurane. Isoflurane is the most commonly used agent in cardiac surgeries, even though it has caused coronary steal phenomena, but only in animal studies. Only in animal studies. Isoflurane can be safely given in renal patients. Okay. Guys, which inhalational agent is most likely to cause diffusion hypoxia at the end of surgery? Normally, this will happen at the end of general anesthesia. When you are switching one gas, patient will develop sudden fall in the oxygen saturation. Why will it happen, guys? And with which gas it will happen? It will happen with a gas called as nitrous oxide. Why with nitrous oxide? Remember, nitrous basically goes into the alveoli, displaces the oxygen outside, takes much place. If you are cutting down nitrous, it has already displaced oxygen. So what will happen? Patient will develop hypoxia. So what are we doing, guys? At the end of surgery, before cutting nitrous, I will increase the oxygen rate, then cut nitrous. Okay? That is called as diffusion hypoxia. Now, guys, regarding nitrous, what we need to remember, nitrous is used at what gas? Nitrous is used as a carrier gas. Now, what is a carrier gas? It cannot be used as a main gas. Why? Because as nitrous, carrier means supporting gas. There is supporting hero and main hero, na? Nitrous is always as a supporter. Yani you use some other inhalational agent, with that you use nitrous. Why? Because it's having a high MAC value. High MAC value of 105. High MAC value means what? Low potent or less potent. What is the color in which nitrous is stored? Nitrous is stored in Neela cylinder, that is blue color cylinder. Nitrous means Neela, blue color cylinder. Okay. Next, nitrous is a very good analgesic. Apart from that, you also need to remember nitrous is avoided in what patients? It is avoided in closed loop surgeries. Why? Because it will expand the air containing cavities, as well as it is avoided in cardiac surgeries as it is increasing the peripheral vascular resistance. Okay. Now, remember I told you nitrous will cause diffusion of hypoxia at the end of surgery. So how you will prevent it? 100% of oxygen you give for 5 minutes and this diffusion hypoxia can be prevented. There is one more thing with nitrous which is called a second gas effect. If you are giving nitrous with halothane, it will, whenever you give nitrous with any agent, any inhalational agent, it will increase the concentration of that agent. That is called a second gas effect. Okay. Coming to the next question, guys. A patient under anesthesia develops unexplained jaundice, elevated liver enzymes after exposure to a volatile agent. Volatile means what, guys? After inhalational agent. Which drug is most likely to be responsible? Come on, guys. After receiving an inhalational agent, patient is developing this after 1 week. Only one drug will cause this. What is that drug, guys? Halothane. Halothane. Remember, halothane. 4H. Whenever anyone is asking you about halothane, halothane starts with H. You have to remember 4 H's of halothane. First H of halothane is what? Halothane will cause hepatitis. Okay? On repeated exposure of halothane, the patient will have halothane induced hepatitis. Next, hyperthermia. Which hyperthermia I am talking about, guys? Halothane is the inhalational agent that causes maximum incidence of malignant hyperthermia. Next, H of halothane, heart disease. In heart disease, halothane is severely contraindicated. Why? Because halothane will cause hypo and brady together. Apart from that, halothane will sensitize the myocardium towards catecholamine that can cause arrhythmias. Okay, last H is what, guys? 4 hits of halothane, always have to remember. Halothane has two maximum, what two maximum? Maximum bronchodilation and maximum muscle relaxation. Okay, as it is causing maximum bronchodilation, it is the second best choice. Initially, it was best choice for bronchial asthma. Now it is the second best. Why? Because it is causing some airway resistance. Hence, it is the second best choice for bronchial asthma. Okay. It causes maximum muscle relaxation. Even though it is an inhalational agent, it can cause some muscle relaxation. Hence, we are avoiding halothane for a patient who is posted for cesarean section. Why? Because in cesarean section, guys, what happens is after cesarean section, there is a risk of postpartum hemorrhage. Why? Why? Because patient might have a atonic uterus. If you give halothane, it will relax the uterus. So it is avoided. Next, most potent inhalational agent among the following. Come on, guys. When I am asking you about the potent inhalational agent, basically I am asking you potency of inhalational agent is determined by what? MAC. And remember, MAC and potency are always opposite. My question could be most potent, or I can also ask the inhalational agent having low MAC over here. Okay, low MAC or most potent, both are same. Why? Because MAC indicates the potency. Remember, guys, whenever anyone is asking you about the potency, most potent, the answer should be HIST. H stands for halothane, I stands for isoflurane, S stands for sevoflurane, D stands for desflurane. Yani ke it is the order of most to least potent. Okay? Order of most to least potent. Now, before halothane, there is one more agent which is called as methoxyflurane, but we are not using that. Okay? Methoxy is having a MAC value of 0.16. Halothane have a MAC value of 0.75. ISO 1.16. Sevo 2. Desflurane 6. So remember, which is having a low MAC value? Methoxy, but we are not using. Then that after that, which is the most low MAC value is what, guys? Halothane. It is the most potent inhalational agent. So if you are remembering in this order, guys, you can never forget it. Now, if you are remembering this order of HISD, remember in the inhalational agent, you have to remember one more thing. There is one more concept called as blood gas coefficient. As MAC was, remember, MAC indicates the potency of inhalational agent. And I told you high MAC is equals to low potent, low MAC is equals to highly potent. There is one more concept called as blood gas coefficient that indicates the speed of onset and recovery. Any agent that is having high blood gas coefficient, it will be slow onset. Any agent that is having low blood gas coefficient, it will be fast onset. Now, guys, some MCQs on blood gas coefficient, if they are asking, don't confuse. If you are remembering this, please don't confuse. Now, over here, I told you what? This was regarding MAC, na? If you remember, HISD, if you remember, just you write from DSH. In the opposite direction, if you write DSH, you will get what? You will get the blood gas coefficient. Yani ki you will get the rapid acting inhalational agent. Rapid acting are in the opposite direction of MAC. D stands for desflurane, having a low MAC value. S stands for sevoflurane, desflurane, having a low blood gas coefficient. Sevoflurane, having a bit more blood gas coefficient than desflurane, then isoflurane, then halothane. Okay, this is regarding what, guys? This is regarding the MAC values and blood gas coefficient. So this, when I am writing in the opposite direction, it means what? Low blood gas coefficient to high blood gas coefficient. Low blood gas means what, guys? Low blood gas means rapid onset. Which is the rapid onset? Desflurane. Okay. So this was regarding blood gas coefficient. Now, as we are discussing a few things, guys, we also have to discuss during anesthesia, we have to monitor some things. What things we have to monitor in the patient during anesthesia? Now, guys, one of the things that we monitor is neuromuscular, but it is not the only monitoring. There are many monitors. Now, in the neuromuscular monitoring, if at all there have been question given to you in this monitor, what is the nerve that is being monitored? First of all, what is this monitoring, guys? This is train of 4 monitoring. Okay, and what is the nerve that is being used? If the question is asking what is the nerve that is being used for train of 4 monitoring, guys, very good, very good, very good. It is the adductor, it is the ulnar nerve, and the muscle that is used is adductor pollicis. Now, guys, remember train of 4 monitoring. Okay, train of 4 monitoring. I'll just give you a brief thing of train of 4 monitoring. Everyone look over here. Okay, I just connect this monitor over here. I connect the monitor to my hand. I have not received any muscle relaxant. Okay, I have not received any muscle relaxant. Now, if I connect the train of 4 monitor, it will give me 4 currents. At 4 currents, my muscles should twitch. My thumb muscle should twitch. Okay, I am stimulating the ulnar nerve 4 times. So look over here. I have not received any muscle relaxant. As I use as train of 4 monitoring is done, what I'll do, what I'll get is, as current passes, first twitch, second twitch, third twitch, fourth twitch. Okay, 4 twitches of equal height I am seeing. Why? Because no muscle relaxant is given. Now imagine, to me, non-depolarizing muscle relaxant was given. Okay, non-depolarizing. If non-depolarizing muscle relaxant is given, what will happen? After giving non-depolarizing muscle relaxant, after 2 minutes, I am going for train of 4. What I will see, as I am stimulating, first twitch will come. Second, it will come. Next, third will come like this. Fourth time when I am stimulating, no twitch. So are you seeing 4 twitch over here? No. So how is the twitch response, guys? How is the twitch response? First twitch was coming like this. Second twitch came like this. Third twitch came like this. And fourth twitch was gone. So basically, when non-depolarizing muscle relaxant is given, how will be the train of 4? You will see a fading effect. How will you will see a fading effect. Okay. Now, if at all I have been received a depolarizing muscle relaxant, everyone look over here. Depolarizing यानी कि scoline. As I have given I have been given scoline, after 2 minutes of scoline, some stimulus is given to me. Now just look over here, guys. First twitch, second twitch, third twitch, fourth twitch. यानी कि 4 twitches are coming. Are you able to see? First twitch. देखो, normally twitch should be like this, but how is it coming? First twitch, second twitch, third twitch, fourth twitch. यानी कि all 4 twitches you are seeing, यानी कि all the amplitude of all 4 twitches is same. It is decreased, but it is same. So guys, look over here. If anyone is asking you, how will be if you take a ratio between the 4th twitch and first twitch, 4th to first twitch, what will be the ratio in case of depolarizing muscle relaxant? यानी कि T4, the 4th twitch and the first twitch both are same, ratio will be 1. Whereas in non-depolarizing, the ratio will always decrease. It will be less than 0.4. In non-depolarizing, the ratio will be what, guys? Less than 0.4. Whereas in depolarizing, it is 1. Okay? If someone asks you after receiving muscle relaxant, which is the first twitch to disappear? Come on, guys. Which is the first twitch to disappear? The first twitch, यानी कि T1 or T4, which is the first twitch? First will come, second will come, third will come, and the first twitch to disappear is the 4th twitch. Okay? And which is the first twitch to reappear in the case of recovery? It is always the T1. Okay? So most common nerve that is being used over here is what, guys? Ulnar nerve, and muscle is adductor pollicis. Adductor pollicis. Okay? Now, if someone asks you train of 4 ratio, remember in depolarizing it is always 1. In non-depolarizing or adequate blockade, it should be less than 0.4. In case of reversal, always the ratio should be more than 0.9 in train of 4. Then only you need to go for reversing. Now, guys, remember what is the first? Remember which is the first twitch to disappear? The first twitch to disappear is what? The T4. First twitch to recover is what? It is T1. T1 is the first twitch to recover. Okay. Now, In monitoring, guys, there was just a neuromuscular monitoring. Again, neuromuscular monitoring is not used for all surgeries. It is used for surgeries like liver surgeries or major surgeries, not that much. Okay. Now, what are the things that are monitored actually in during anesthesia? You monitor for oxygenation, which is by pulse oximetry. This pulse oximetry usually works on a law called as Beer-Lambert's law. Beer-Lambert's law. Okay, you monitor the patient's ventilation. How will you monitor the patient's ventilation? You monitor the patient's ventilation by a thing called as capnography. You monitor circulation. How circulation is monitored? By BP, ECG and TEE, which is called as transesophageal echocardiography. In the BP, guys, there are two things to monitor. Either you go for IBP for major surgeries, invasive blood pressure monitoring, or either you go for NIBP, that is the normal BP cuff. If IBP you are using, then you have to cannulate which artery. The radial artery is cannulated. And how will you know the patency of radial artery? With the help of Allen's test. Next is ECG, guys. ECG, you are not monitoring 12 leads. You are just monitoring 2 leads, lead 2 and lead 5. Lead 2 detects what? It detects arrhythmias, and lead 5 detects what? It detects ischemias. Okay. There is one more monitoring in cardiovascular that is called as TEE, transesophageal echocardiography, which is usually done for major cardiac surgeries, or if you are suspecting venous air embolism. Venous air embolism, guys, you know what is the murmur that you see in venous air embolism? That is called as mill-wheel murmur. Mill-wheel murmur. Okay. Now, temperature also you monitor during anesthesia. What temperature? Core temperature and peripheral temperature. The most common site for core temperature monitoring is what? It is the esophagus. Okay. But it is not that accurate. The most accurate site for monitoring the temperature is what, guys? It is the pulmonary artery. Pulmonary artery is the most accurate site, but again, it is an invasive thing. That's why commonly we use esophagus for temperature monitoring. Okay. One more thing you monitor, guys. What you monitor is what? Sometimes the patient will be telling that, doctor, during surgery, I was able to hear all the things. Yani ke patient is basically remembering all the things, right? If the patient is having awareness, to monitor whether the patient was aware or not during surgery, you have to go for a monitoring which is called as what? BIS monitoring. Come on, guys, what is BIS? BIS is nothing but bispectral index, where you are keeping some electrodes on the frontal occiput and then you are taking EEGs. BIS calculates the sum of EEGs. Bispectral index calculates the sum of EEGs. Okay. Now, guys, in BIS you might get after like summing up all the EEGs, you might get values like 100 or 40. 100 means fully awake and 40 means total knocked off. Okay. Now, guys, remember why it can happen, why this awareness can happen when the thing that is usually given to the patient. Remember, what is the thing that maintains the patient in an unconscious state? Inhalational agent. If the inhalational agent is not acting, then only patient will have what? Then only patient will have this awareness. So remember, BIS values less than 40 means deep hypnotic state. Remember, 40 to 65 is the BIS required for surgery. 65 to 85 is the BIS required for sedation. Okay. Now, guys, look over here. Next question. A patient was planned for surgery under general anesthesia. In the induction phase, rocuronium was given, but the anesthetist did not succeed in intubating. Which could be the best reversal agent used? Now, guys, if at all the patient has not been intubated or the anesthetist has failed in intubation, if you have given rocuronium, which could be the reversal agent that could be given over here? Remember, guys, normally for all muscle relaxant except rocuronium and vecuronium, we are commonly giving neostigmine. Okay, neostigmine is very commonly given, most commonly given. Physostigmine cannot be given as a reversal. Why? Because it crosses the blood-brain barrier. Okay. Next, Sugammadex. Remember, Sugammadex is a modified gamma cyclodextrin that is specially given for rocuronium and vecuronium. Glycopyrrolate, though, never it is given as a reversal agent. Glycopyrrolate you add with neostigmine and give it. Why? Because neostigmine will cause bradycardia, hence you add glycopyrrolate. So for sugammadex, remember sugammadex is the reversal agent used for rocuronium and vecuronium. So as I told you, reversal agents, there are many reversal agents: neostigmine, pyridostigmine, L-cysteine, edrophonium. Neostigmine is a cholinesterase inhibitor that can cause bradycardia. Hence with neostigmine, we are adding what? Either you add glycopyrrolate or either you add atropine and give it to the patient. Okay. Next, in the question, rocuronium was given. So what is the reversal agent given for rocuronium? It is sugammadex. For rock and vecuronium, it is always sugammadex. Now guys, in normal surgery, when will you come to know that now you have to reverse the patient? Yani surgery is done. What is the best sign that detects that patient can now be reversed? If you ask the patient to lift his head, yani if he is having a sustained head lift, that means his muscles are now working. He can breathe spontaneously. Now you can extubate the patient. So that is a very good sign. That is a clinical sign. Sustained head lift for more than 5 seconds. That is the best bedside sign. Or if you see a train of 4 ratio of more than 0.9, then it is overall the best clinical sign for adequate reversal. For more than 5 seconds, guys. For more than 5 seconds. Okay. Next. Now coming to the most important slide for general anesthesia. Everyone look over here. If a person is coming with heart disease, which is the IV induction, which is the muscle relaxant, which is the inhalational agent. Remember guys, heart disease patient, what you need to remember is heart. Always remember this. Okay? For heart disease, always remember heart enjoys very deep inhalation. Heart enjoys very deep inhalation. When I am telling this, enjoys means heart enjoys. E means what? Ethomidate should be given to a patient who is having heart disease. Remember, if a patient is having heart disease, which is the IV induction, which is the muscle relaxant, and which is the inhalational agent we are discussing. Okay? Okay? Next. Heart enjoys very. V stands for what? Vecuronium. Vecuronium should be given. Why? Because vecuronium is a cardiostable muscle relaxant. Next, inhalational agent, which is the inhalational agent, guys. Remember, the best inhalational agent is what? Desflurane. But again, desflurane cannot be used. Why? Because desflurane is commonly kept in a vaporizer, which is very costly, as it is having a low boiling point. It is very costly vaporizer. Hence, we are not using desflurane. We are commonly using isoflurane. Okay? Isoflurane is the most commonly used. Best is desflurane. Next. Asthma. When a patient is suffering with asthma, asthmatic patient is posted for surgery, which is the IV induction agent to make him unconscious. You always remember, asthmatic kids always seek help. Asthmatic kids always seek help. What does it mean? Okay? IV induction agent of choice, K stands for ketamine, the best IV induction agent. Okay? Always yani ke any muscle relaxant, but I would suggest that avoid benzyl isoquinoline. Why? Because they release histamine. Avoid benzyl isoquinoline. Seek help. Remember, the best agent is sevoflurane, inhalational agent, and second best is halothane. Both are causing bronchodilation. Next, for shock, what we need to remember? Shock patient. Shock kills the patient directly or indirectly. Directly or indirectly. Yani ke, we have to remember this. K stands for ketamine. Ketamine is the IV induction agent of choice in shock patient. P stands for pancuronium. Remember RRR, pancuronium. Pancuronium, it can be given in shock. It increases the BP and pulse rate. Directly or indirectly, D stands for desflurane, I stands for isoflurane. Next, Daycare surgery. For Daycare surgery, what do you have to remember? But ketamine is not given in heart disease. Ketamine is not given in ischemic heart disease. It is given in cyanotic heart disease. Ethomidate is the best for heart disease, cardiostable. Okay. Daycare surgery. Daycare surgery, patient may sleep. Okay. Patient. P stands for what, guys? Propofol is a IV induction agent of choice for daycare surgery. Muscle relaxant is what, guys? Mevacurium, the shortest acting muscle relaxant. And sleep, S stands for sevoflurane. may sleep directly, you can remember directly. D stands for desflurane, that is the second best choice. Second best choice. Next is what, guys? Neurosurgery. For neurosurgery, what we should remember as a mnemonic: neurosurgeons. Neurosurgeons treat all safely. Okay? Treat all safely means what? The IV induction agent of choice is thiopentone. Muscle relaxant, any muscle relaxant could be given, and safely S stands for what, guys? Sevoflurane. Okay? Sevoflurane is the best inhalational agent for neurosurgery. Apart from Sevo, you can also use isoflurane. Isoflurane. Okay, guys, this slide is very, very, very important. Okay. Next. Okay. A child develops high grade fever, muscle rigidity, tachycardia, and rise in EtCO2 during surgery under halothane and succinylcholine. What is the first step in management? Guys, patient is developing a high temperature, muscle rigidity, tachycardia. All these are pointing towards what? All these are pointing towards a diagnosis of malignant hyperthermia. Malignant hyperthermia. Come on, guys. For malignant hyperthermia, what is the... Come on. 10 to 12 more MCQs are there. Please bear with me. Malignant hyperthermia, which is the treatment of choice. Remember, the treatment of choice for malignant hyperthermia is what? IV dantrolene sodium. But what is he asking over here? What is the first step that could be given over here? The first step is what? Which is the thing that is worsening halothane and succinylcholine. First step is stop the triggering agents. Then after stopping triggering agents, the second is give IV dantrolene sodium. Then cool the patient, and then if at all patient is having acidosis, you give sodium bicarbonate. Sodium bicarbonate. Now regarding malignant hyperthermia, guys, in anesthesia there are many things that can cause malignant hyperthermia. Lignocaine can cause malignant hyperthermia. Scoline can cause malignant hyperthermia. Okay? And all inhalational agents can cause malignant hyperthermia. Maximum incidence is seen with halothane. The safest inhalational agents are nitrous and xenon, which can be safely given in malignant hyperthermia. Some points of malignant hyperthermia. Remember, malignant hyperthermia is an autosomal dominant disorder. The gene that is involved is RYR1 gene. Okay, RYR1 gene. Okay, and malignant hyperthermia is you are giving the patient scoline and it will trigger the abnormal ryanodine receptors. Once the ryanodine receptors are triggered, patient it will basically release calcium that will cause muscle spasm. This spasm starts from what muscle? Masseter muscle, thereby whole body gets involved. Masseter muscle and thereby whole body gets involved. Diagnosis is by halothane caffeine test, and the treatment of choice for malignant hyperthermia is IV dantrolene sodium. IV dantrolene sodium. Okay. Next, guys, as we are discussing EtCO2, remember he told what? EtCO2 is being rising. So we have to discuss something about EtCO2. EtCO2 is end-tidal carbon dioxide. Yani ke, when you are doing this exhaling carbon dioxide, it will measure how much of carbon dioxide is exhaled. After intubation, if you are in the trachea, this gives the best thing that or the best sign that you are in the trachea. EtCO2. That is also called as capnography. There are 4 phases of EtCO2, guys. 1, 2, 3 and 4. What is the first phase of EtCO2? First phase of EtCO2 is called as inspiratory baseline. The second phase of EtCO2 is called as expiratory upstroke. This is expiratory upstroke. The third phase is called as alveolar plateau. And fourth phase is called as inspiratory downstroke. Inspiratory downstroke. Now, guys, in between phase 2 and phase 3, there is an angle called as alpha. And between phase 3 and phase 0, angle called as beta. This is the angle where EtCO2 is measured. EtCO2 is measured at this angle called as beta. Okay, very, very important. And what is the normal value of EtCO2? 35 to 45 mm of Hg. And this will be the normal EtCO2 graph. Okay, but after intubating, if you get some different graphs, then what you will get. Yani ki after your intubation is done, if you get an EtCO2 like this, is there any graph coming? No. You are seeing a flat EtCO2. What does it indicate, guys? Flat EtCO2 means what? You are not in the trachea, you are in the esophagus. Yani ki esophageal intubation, you will see a flat EtCO2. Apart from that, EtCO2 is also flat if at all you have intubated the patient, but the patient had developed cardiac arrest. In case of cardiac arrest also, you will see a flat EtCO2. Or in case of accidental extubation, you will see a flat EtCO2. Okay, sudden EtCO2 0 means you will see flat EtCO2 in accidental extubation. Okay, shark fin capnography. Shark fin capnography, other form of EtCO2. Just look over here, guys. EtCO2 appearing like this. Okay, normally it should come like this, guys, but it is appearing like this. Shark fin means what? Shark fin, it looks like a shark. It looks like a shark. Okay, so this is commonly seen if the patient is having bronchospasm. And how will be the EtCO2 value? It will be normal to high. Shark fin capnography in case of bronchospasm. Just look over here, guys. Next, after intubating, if you are getting this EtCO2, is it normal, guys? No. Yani ki it is slowly increasing. Step ladder pattern of EtCO2 increasing. Of 100, it is seen in malignant hyperthermia, as in our case. In malignant hyperthermia, you will see. If you see an EtCO2 after intubation, you are getting EtCO2 like this. Yani ki it is not starting from the baseline, above the baseline. Okay? That means patient is re-inhaling his own carbon dioxide. When will it happen? When the thing that is absorbing carbon dioxide is exhausted. In case of soda lime exhaustion. In case of soda lime exhaustion, or in case of faulty expiratory valve, you will see this kind of EtCO2. Okay. Next, guys. Patient was having a normal EtCO2. Suddenly EtCO2 is falling. This usually happens in major surgeries where the patient is at risk of developing venous air embolism or fat embolism. In those cases, you will see a sudden fall in EtCO2. The answer is venous air embolism. The murmur that you see is, I have already told you, mill-wheel murmur. Mill-wheel murmur. And what is the investigation of choice over here? Transesophageal echocardiography. Now look over here, guys. Curare notch capnography or EtCO2. EtCO2 appearing like this. Normally it was appearing, but now a small curare notch is developing. What does it indicate? Development of curare notch means what? Patient EtCO2 was normal, but now muscle relaxant effect has gone. Suddenly patient has started spontaneous breathing. You will see this. Okay? Curare notch. And whenever you see curare notch EtCO2, the next management would be what? If the surgery is still there, you have to give the top-up dose of muscle relaxant. Okay. Next, guys. If you have increased the respiratory rate, normal is 12 to 18, you have given 30 of respiratory rate. More washing of carbon dioxide has happened. So what will happen to the EtCO2? Due to hyperventilation, EtCO2 appears like this. If at all you have given a respiratory rate of 6, it is you are hypoventilating, so you will get an EtCO2 like this. In case of hypoventilation, you will get an EtCO2 like this. Okay, so hyperventilation and hypoventilation. This was regarding what, guys? EtCO2. Now coming to the next question, guys. A 45-year-old male patient with acute intestinal obstruction and vomiting is posted for emergency laparotomy. He is alert and dehydrated. He has not been fasted. Yani ki patient is not in fasting state. During induction, which of the following is the most appropriate airway management plan? So basically he is asking if the patient is full stomach and you want to give general anesthesia. He is full stomach. And if you want to give general anesthesia, how will you give? You have to give general anesthesia to this patient, full stomach patient, by a thing called as RSI. What is RSI, guys? RSI is rapid sequence induction. Come on, guys. What's the answer over here? A, B, C, D. What's the answer? I cannot remember. I will pre-oxygenate, induce with propofol. Will I ventilate with mask? No. Bag mask ventilation is not done. Why? Because that can cause as the patient is full stomach, that can cause aspiration. Can you give midazolam under deep sedation? No. If you give deep sedation, patient will aspirate. No. Can you induce with ketamine? Yes, ketamine can be done, guys. Ketamine induction can be done. Mask ventilation, but still mask ventilation is not done. So this also not done. What is done, guys? Pre-oxygenate, induce with propofol, give choline, apply cricoid pressure, and then intubate without mask ventilation, which is called as RSI. So remember, guys, cricoid maneuver or Sellick's maneuver or cricoid pressure is nothing but putting pressure on the cricoid in order to block the esophagus. So remember, RSI is done in what patients? Patients who are at risk of aspiration. Obese patient, pregnant ladies, GERD or emergency. We go for RSI. What are the steps of RSI? We pre-oxygenate with normal mask. What is being prevented, guys? Bag mask is avoided over here. Bag mask ventilation is not only avoided in RSI patient, it is also avoided if the patient is having congenital diaphragmatic hernia. Why? Because the gases can go into the stomach and the intestine too. Okay. So anyways, next, after pre-oxygenation, you immediately give IV induction. Immediately after giving IV induction, before giving muscle relaxant, you tell your assistant to put pressure on the cricoid cartilage so that esophagus is closed. What is that pressure called as? That pressure is called as Sellick's maneuver, or it is also called as cricoid pressure. Cricoid pressure. Now, guys, remember, when do you remove this Sellick's maneuver? This is also important. Once intubation is done and you inflate the cuff, very, very important. You basically intubate the patient with a cuff tube. So once you intubate and inflate the cuff, then Sellick's maneuver is removed. This was one time asked also. When do you remove Sellick's maneuver? After intubation, after inflation of the cuff. Okay. Next, guys, a 60-year-old patient who's with trauma in emergency department arrives. He's having hypotension and active bleeding. The anesthesiologist plans for rapid volume resuscitation. Which cannula should be used? Come on, guys. It's regarding the IV cannula. IV cannula, many sizes are available. Okay. So which should be used over here? It is always the largest bore IV cannula. Which is the largest? Largest is 14. Okay. Cannula sizes are from 14 till 26. 14 is the largest. Smallest is what, guys? It is 26. Always for shock-like condition, you have to give a large bore IV cannula. Okay. Smallest is 26 gauge, purple in color. Largest is this one. Okay. Remember, the most commonly used for surgeries. We are using 20 and 18. For shock-like conditions, we are using 14 and 16. For pediatric patients, we are using 24. For neonates, we are using 26. Okay. 17 is also there, white, which is not used, but these are the cannulas which are used. Okay. Now, guys, look over here. Regarding IV cannulas, they have been questioned. What questions have been regarding the cannula colors and all? Remember, guys, colors, gauze and flow rate. Remember, the mnemonic is, oh great God, please bless your people. When I am telling this mnemonic, oh great God, please bless your people, O stands for what, guys? Orange IV cannula, which is 14 gauze. Okay. G stands for what? Gray color cannula, which is 16 gauze. One more G stands for green cannula, 18 gauze. Please, P stands for pink cannula, 20 gauze. Bless, blue stands for B stands for blue, 22 gauze. Your Y stands for yellow cannula, which is 24 gauze, and people, P stands for purple color, which is 26 gauze. And what is the flow rate of the fluid flow rate over here? Now we have to remember, guys, from the bottom. Okay, when you are using this purple cannula or 26 gauze, it will deliver 10 ml per minute of fluid. Okay, yellow, it will deliver double of 10 is 20 ml per minute. Okay. Next is what? Yellow. Yellow will deliver, blue will deliver how much, guys? 30 ml per minute. Next, pink color. Pink color will deliver 50 ml per minute. 18 gauze cannula will deliver, double of 50 is 100 ml per minute. 16 will deliver 100 ml per minute, and 14 will deliver 270 ml per minute. Okay, this is the gauze size, and this is the flow rates that we need to remember, guys, regarding the IV cannula. Now, guys, coming to the next question. During general anesthesia, an intern accidentally connects a gray cylinder of white shoulder black. He connects a gray cylinder instead of white shouldered black cylinder to the yoke. The patient develops desaturation. First of all, guys, accidentally connecting a gray cylinder. We wanted to connect what? A black body white shoulder. Black body white shoulder is what, guys? It's a black body white shoulder is oxygen cylinder. But instead of oxygen, he has connected gray. Gray is what cylinder, guys? Gray is complete gray cylinder. It is always the carbon dioxide. Okay. So what is the likely gas over here which is being connected? It is carbon dioxide cylinder. It is a carbon dioxide cylinder. Before going to the color coding of the cylinder, we have to remember something about the machine, guys. Machine. Remember, this is the Boyle's machine, which is being divided into systems. What systems? It is divided into the low pressure system, intermediate pressure system, and low pressure system. So remember, low pressure, intermediate, and high pressure system. High pressure system, cylinders, yoke valve assembly, pressure gauge will be there. Intermediate, flow control valve, oxygen proportionating devices, oxygen flush. Remember, oxygen flush is an important part, guys. Important part. Over here, this in the machine over here, it delivers 35 to 75 liters per minute of oxygen when you press this. Okay. So these are the parts of machine that we don't have to remember that much. But the main parts of the machine, cylinder. Cylinder, what is the material that it is made up of? It is made up of molybdenum. And this molybdenum are non-MRI compatible. We cannot take into the MRI room. If you want to take an oxygen cylinder to the MRI room, then it has to be made up of either titanium or either aluminium. And what are the sizes of cylinder? Smallest is A, largest is J. And the most commonly used size cylinder is what, guys? Size E cylinder. Size E cylinder. Now we have to remember the color coding. In order to prevent the, basically, just to easily identify the cylinder, what gas is there in the cylinder, color coding has been given. Okay. So body is being given a different color, shoulder is being given different color. So what we need to remember is oxygen. Oxygen is basically as a bodyguard. The bodyguard always wears what color dress, guys? Black suit with white shoulder cuffling. So oxygen is also a bodyguard to us. So it will be black body, white shoulders. Black body, white shoulders. Okay. Air cylinder. Air cylinder is opposite of oxygen. That is white body, black shoulder. In some countries, air cylinder is having gray body and black and white shoulder also, guys. Okay. So normally it is white body and black shoulder. Nitrous is what? Nitrous Neela. Neela means what? Completely blue cylinder. Nitrous, always remember, nitrous Neela, completely blue. There is one more gas called as Entonox, guys. Heard about Entonox? Entonox is what? 50% oxygen, 50% of nitrous. That means it is having blue body, white shoulders. Okay, normally we are using for painless labor. We are using Entonox gas inhalation for the patient. Okay. Now, guys, remember, this was the color coding of the cylinder. Sometimes they might give you a pipe picture and tell what is the pipe. Remember, pipe are central lines. This picture that is being given over here is DISS, diameter index safety system, where you plug the pipe into the system. Now, what is the color coding of the pipeline? Oxygen, air, nitrous, and vacuum. Remember, if you remember the color coding of the cylinders, just remember the shoulder. Shoulder will be the color coding of the pipeline. Shoulder color. Oxygen is having white color. Okay, just shoulder color you have to take. Air is having black, so air pipe will be black in color. Nitrous, total body is blue, so blue color. Vacuum, again, remember, vacuum starts with the alphabet V. Add a stroke, it becomes yellow, Y. So vacuum color pipe is yellow. This is regarding what, guys? This is regarding the color coding of the cylinders. We also need to remember the pin index system. So cylinders are attached to the machine with the help of a steel assembly called as yoke valve assembly. In that yoke valve assembly, there is a system that prevents wrong attachment of the cylinder, which is called as pin index system. Okay? They are basically pins which are present on the machine and holes which are present on the cylinder. Okay? We are just labeling them 1, 2, 3, 4, 5, 6 and 7. Different gases are given different pin index system. It is said Air is given a pin index system of 1 and 5. It fits in the first and fifth port. Oxygen 2 and 5. Nitrous 3 and 5. Antonox pin index system is 7. Carbon dioxide is 1 6 or 2 6. Now guys, these four gases you can easily remember. Just look over here guys. Air. When anyone is asking you about the air pin index system, air starts with the alphabet A. So first of all, before going for alphabet A, one thing is common between air, oxygen and nitrous. What is that thing that is common? The second pin index system is 5. So we just have to remember the first one. So for remembering first one, air is starting with alphabet A, and alphabet A is the first alphabet of English. So it will be 1, 5. Oxygen, when you are writing it, is O2. So it will be 2, 5. Yani O2, this 2 will come over here, 2, 5. Nitrous meaning what? 2 molecule of nitrogen and 1 molecule of oxygen. That is 3 molecules. So it will be 3, 5. Antonox is very simple. It is a pretty like 7 alphabets are there in Antonox. E, N, T, O, N, O, X. So it is 7. So that is regarding the pin index system. We also need to remember something about vaporizer. Vaporizer is a device that stores liquid inhalational agent, which is made up of what material? It is made up of copper material. Different vaporizers are required for different gases, and different color coding is also given. But desflurane requires a special vaporizer because it is having a low boiling point. Now, what is the color of halothane vaporizer? Halothane is fiery red. Remember guys, hellfire. Halo means hell. Hellfire is fiery red in color. Halothane is stored in red color vaporizer. ISO is stored in purple vaporizer. Sivo, I have already told you, Sivo is sevaiya, yani it is stored in yellow color vaporizer. Whereas desflurane yani desi jersey color is what? Blue in color. Okay? Recently we won the Women's World Cup. What were the jersey color they were wearing? Our desi girls, they were wearing blue color. Okay? So that's regarding the desflurane. Now, next question guys. 65-year-old patient is being ventilated through a Mapleson circuit. Which circuit is most efficient for spontaneous ventilation? Guys, remember he is asking for spontaneous ventilation. Whenever their question is for spontaneous or controlled ventilation and he's asking about circuit, you should write one thing, SACD. That you should remember. SA is what? S is spontaneous. For spontaneous, the circuit of choice that is used is Mapleson A circuit. CD is what? C is controlled. For controlled ventilation, the circuit of choice is D. So what's the answer over here guys? Carbon dioxide, I told you 1, 6 and 2, 6. Okay. So look over here. So circuit of choice for spontaneous ventilation over here is what? It is Mapleson A circuit. Now as we are discussing circuit, we will discuss some points of the circuit guys. Mapleson circuit. Mapleson A was the first introduced circuit, which was also called as Magle's circuit because Magle's did some modification in this circuit. It is regarded as a circuit of choice for what ventilation? It is regarded as a circuit of choice for spontaneous ventilation. In order to prevent rebreathing, we keep the fresh gas flow equal to minute ventilation. Now everyone look over here. In this circuit is nothing but a pipe guys. In this circuit, this was the outer part and this was the inner part. The inner part of the circuit, remember the inner pipe of the circuit was responsible for expiratory gases and the outer part of the circuit was responsible for inspiratory gases. Okay? Basically, inner should be inspiratory, outer should be expiratory. But this was the experimental circuit, Mapleson A. Hence, inner was expiratory and outer was inspiratory. Okay? Next, B and C are not at all used. Mapleson D circuit is also called as B, R is silent, Bain circuit. This is regarded as the circuit of choice for what ventilation? Controlled ventilation. Okay, Mapleson D circuit, B and C are not used. In order to prevent rebreathing, we give fresh gas flow which is equal to minute ventilation. Now in this circuit also one modification was done. What was the modification guys? This is the circuit. Okay, this is the outer pipe and this is the inner pipe. What did Bain do? Bain is the guy guys, Archie Bain. What did he do? He told the inner will be responsible, the inner tube will be responsible for inspiratory gases, Outer tube should be responsible for expiratory gases. Okay, that's regarding what? Mapleson A and Mapleson D circuit. Okay, whatever I am writing, guys, it's very, very important. Mapleson, then came the Mapleson E circuit. Mapleson E circuit is also called ISTPs, is a very much incomplete circuit, bagless and a valveless circuit used for weaning of the patient from ventilator. Then came the Mapleson F circuit, which is regarded as circuit of choice for controlled as well as spontaneous ventilation in pediatrics. This is also called, as other name for this circuit is Jackson-Rees modification. Jackson-Rees modification. This is a control. This is circuit of choice for control as well as spontaneous ventilation in pediatrics. Okay, that was regarding semi-closed circuit. Now, if you are ventilating the patient with closed circuit, we use a thing called as carbon dioxide absorber. It could be two things, either soda lime or either bara lime. Most commonly uses soda lime. Now, what is the soda lime granules made up of? 80% of soda lime granules are made up of calcium hydroxide, which is the major component or the major chunk of soda lime. 16% water, 3% they are made up of sodium hydroxide. Even though it is 3%, but it is a main component without which soda lime cannot be formed. And 1 to 2% is made up of silica, which is just making the soda lime granules hard. Okay, now guys, whenever you are using soda lime, 3 agents should be there which should never be used. 3 inhalational agents should be absolutely avoided with soda lime. What 3 inhalational agents? CT scan agents should be avoided with soda lime. C stands for chloroform. Chloroform तो आजकल यूज भी नहीं कर रहे हैं हम लोग, ठीक है. T stands for trilene. Trilene can cause can form phosgene and triacetylene, which can cause ARDS, so we are not using. Next, S stands for sevoflurane. Sevoflurane is also avoided when you are using closed circuit. Why? Because if you give sevoflurane at a lower flows, it will react with soda lime to form what? Compound A or olefin, which is a nephrotoxic compound. Okay, that is regarding soda lime. One more agent is there which is called as bara lime. Guys, remember bara lime is, if you are not using soda lime, you use bara lime. Okay, but the agents which are avoided with bara lime are dye agents. Dye agents, if you use, patient will die. What dye agents? D stands for desflurane, I stands for isoflurane, E stands for enflurane, which is the most epileptogenic also. Epileptogenic. Okay, why it is avoided with bara lime, guys? Why? Because they react with bara lime to form carbon monoxide gas. Carbon monoxide is most commonly formed with what? With desflurane. Desflurane se more carbon dioxide can be formed. Carbon monoxide can be formed. Okay. Next, guys. A 55-year-old patient is undergoing left thoracotomy. Requires 1 lung ventilation. Which tube is most appropriate? Come on, guys. 1 lung ventilation ke liye which tube will be used? If you just want to ventilate 1 lung, can you use normal tube? No, sir. Can you use flexometallic? No, sir. Can you use ray tube? No, sir. Why, sir? We'll just look over here. If you use those, what will happen? Everyone just look over here. You will get the answer clear. So, if you are using a normal tube or a flexometallic tube or a race tube, all these tubes will fit in the trachea, mid of the trachea. If your tube is fitting at the mid of the trachea, both lungs will be ventilated. But here we require 1 lung ventilation. So for requiring 1 lung ventilation, we have to use a long tube which is having a bronchial lumen as well as tracheal lumen. For 1 lung ventilation, we use a tube called as double lumen tube. We use double lumen tube, which is having a bronchial lumen as well as tracheal lumen. After placing this double lumen tube, how will you confirm that your double lumen tube is placed properly? After placing this double lumen tube, the placement can be easily confirmed by fiber optic bronchoscopy. Fiber optic bronchoscopy. Okay, that's for double lumen tube. For normal endotracheal tube placement, how will you confirm? By capnography, guys. By capnography. Okay. Now, guys, a semi-conscious trauma patient with clenched teeth. Patient is having clenched teeth and spontaneous breathing needs temporary airway patency. Which airway device is preferred? Come on, guys. Which airway device should be preferred in this patient? He's having clenched teeth. His mouth is not open. Can you put a Goodell's airway? No, sir. Why? Why? Because he's not able to open his mouth. Can you put an endotracheal tube? Clenched teeth are there. Okay, just to make the patency. Patient might be patient is conscious only, but semi-conscious. Na endotracheal tube, why it is need and all. Laryngeal mask airway, again the patient is not allowing you to put. Just to maintain the patency, put the airway from the nose so that it can be easily, the patient can be easily ventilated and all. Okay, nasopharyngeal airway. Nasopharyngeal airway. So look over here, guys. Nasopharyngeal airway. Nasopharyngeal airway. This is the airway device. Okay, the exact size of nasopharyngeal airway I am just showing you how the exact size can be determined. You keep the nasopharyngeal airway between the nose and the tragus of the ear, and you measure the size. Okay, but remember, whenever you're using nasopharyngeal airway, normally you use for maintaining the patency. But if the patient is having skull base fracture or bleeding, never use it. Why? Because it can easily go into the cranium and it can damage the brain. If at all patient is having skull base fracture. Okay? Goodell's airway. Goodell's airway is oropharyngeal airway. Goodell's airway size can be determined by how, guys? By keeping it between the tragus of ear and angle of mouth. Keeping it between the tragus of ear and angle of mouth. Okay, that's regarding the Goodell's airway. Now, guys, next. During induction, a 50-year-old man with rheumatoid arthritis developed cannot intubate, cannot ventilate scenario after failed laryngoscopy and supraglottic placement. What is the next step? Come on, guys, straightforward answer. No jumping into any options. Cannot intubate, cannot ventilate. यानी कि we have tried laryngoscopy, we have tried LMA, we have tried all the things. सब फेल हो गया. अभी क्या करेंगे? इमरजेंसी में है. आप क्या वेट करेंगे पेशेंट के वेकअप होने का? No. Patient, if at all you are waiting, patient might develop hypoxic brain injury. ठीक है? Can you repeat the laryngoscopy? No. Can you wait for back mask ventilation? Ventilation has already failed. You go for surgical cricothyrotomy or transtracheal jet ventilation. ठीक है? If surgical was not there, you can go for needle cricothyrotomy. But needle cricothyrotomy is a temporary procedure. You have to convert it into surgical cricothyrotomy after some time. Okay. So guys, remember regarding difficult airway. Remember difficult airway. If you are anticipating, they are plan A, plan B, plan C, plan D. Plan A is what, guys? You go for laryngoscopy. 3 best attempts of laryngoscopy. But first attempt of laryngoscopy, if you are failing, again don't do the same thing. Take the different laryngoscope blade, change the position of the patient, take bougie or something. Okay, so 3 best attempts. If they are failing, that is plan A has failed. Okay, plan A is you go for laryngoscopy. If plan A has failed, always remember, guys, your aim should be ventilation. I have seen many anesthetists making this mistake. If plan A has failed, what they will do, they will only feel that, okay, I have to intubate, or I have to put the tube inside the trachea. If plan A has failed, your aim should be what? Ventilate the patient. If not by endotracheal tube, it is very simple. Ventilate the patient through what? Plan B, that is LMA, laryngeal mask airway, where you are putting the laryngeal mask airway into the patient's mouth and you are ventilating. Supraglottic airway device and all. Okay? If plan B has failed, if at all supraglottic airway device has failed, then you go for plan C. Plan C is what? You remove the supraglottic airway, you hold the mask, you tell your assistant to do the bag. Yani ke 2% technique of ventilation is done. That is plan C. If 2% technique is failed, then you have to declare CICV, cannot intubate, cannot ventilate. In this scenario, you have to go for surgical cricothyrotomy. Okay? Surgical cricothyrotomy. This is the tracheostomy tube, guys. Okay. Now, as we are going for the plan A, the difficult airway and all, something about airway, something about intubation and tubes we have to remember. Okay. Airway, what we need to remember, what is the narrowest portion of the adult airway? It is a glottic opening, whereas in the children, it is the subglottic. Now, if you are intubating the patient, now guys, remember, if you are intubating the patient, what you need to do first is the position, then take the laryngoscope, then you will get a view or the classification, which is Cormack-Lehan grading and all, then you intubate the patient. Now, what is the position for intubation, guys? For normal patients, we go for sniffing morning air position. For obese patient, we go for ramped up position. Ramped up position for obese. Okay? In normal patient, we go for sniffing morning air posture. In sniffing morning air posture, where is the flexion and where is the extension, guys? The flexion is at the cervical spine and there is extension at the atlanto-occipital joint. Okay? Next, after giving the position, you take a laryngoscope in your hand, introduce the laryngoscope, lift the tongue, lift the epiglottis, you will see the view of laryngeal aperture. If whole laryngeal aperture is easily visible to you, basically laryngeal aperture visibility is called as Cormack-Lehan grading. Okay, if whole laryngeal aperture is easily visible, that is grade 1. If only posterior wall is visible, only posterior wall is visible of laryngeal aperture, that is grade 2. Grade 3 means what? Only epiglottis visible. And grade 4 means what? Epiglottis is also not visible. Epiglottis is also not visible, that is grade 4. So once you have, basically we are doing what? We have given the position, we have lifted the tongue and epiglottis, and now we are seeing the vocal cords. Once you see the vocal cords, what's your aim? Next you have to introduce the endotracheal tube. Will you introduce an LMA? No sir, LMA के लिए ये सब करने की जरूरत नहीं है. LMA had to be introduced blindly. ठीक है, so endotracheal tube are the best way to secure the airway. ठीक है, best way to secure the airway is by endotracheal tube. So as we are discussing about endotracheal tube, there are two types of endotracheal tube. Red rubber tubes which were used previously, but these were high pressure and low volume. High pressure, look at the scuff guys, high pressure, which was causing tracheal mucosal injury. Tracheal mucosal injury. Due to this reason, we are not at all using this tube, red rubber tube. We are using what tubes? We are using PVC tube. PVC tubes are polyvinyl chloride tubes, which are low pressure, high volume cuff. Low pressure, high volume cuff. Okay? And once you have intubated, how will you confirm, guys? There are many things, guys. Auscultation and all are there. But best way to confirm the intubation is by capnography. Very, very important. We have already discussed capnography. Okay. Now, so this was regarding the endotracheal tube. Now, guys, remember, apart from endotracheal tube, if at all you have failed in intubation, the second step for difficult airway management was what? LMA insertion. We have to discuss about LMA. Are LMA a definitive airway? Never, sir. LMA are non-definitive airway. Okay, we have to discuss something about LMA generation. There are two generations of LMA, first and second. When do you call first generation? When it is only having a single lumen. Okay, classical LMA. This is a classical LMA. Our LMA that can be easily folded is a flexometallic LMA. This is Cobra LMA. And last one is Ambu Aura LMA. All are having single port. Okay, so these are first generation. One more port was added to this LMA and it became the second generation LMA. In second generation LMA, what we are having? LMA ProSeal is there, LMA Supreme is there, iGel LMA made up of silicone, which is called as iGel LMA, Slipa is there, Streamliner of pharynx, and Ambu Gain is there. Remember, Ambu Aura 40, it's a company name. It is first generation. Again, it was asked. That's why I have included. Ambu Gain is a second generation LMA where you are having an additional port through which you can put a Ryle's tube. In all these LMAs, you can put a Ryle's tube and deflate the stomach. Those are second generation LMAs. Okay. Next. A 55-year-old patient collapses in the ward. He is unresponsive. He is apneic and has no pulse. What is the next best step? Okay. Guys, remember, he is unresponsive. Apneic has no pulse. So, yani we have already checked the response. We have already checked for the pulse and breathing. What's the next best step? What's the answer, guys? The next best step is start high quality chest compression. Okay? High quality chest. The best outcome of your CPCR depends upon the chest compressions. Okay, guys? High quality chest compressions. Now, something about chest compressions and all, or something about CPCR. Remember, guys, if at all you see a person suddenly collapse, what is the first step that we need to do? We need to check for the response. If he's not responding, you call for help. After calling for help, okay, you are checking for the pulse and breathing. If he is not having pulse and if he's not having pulse and breathing, then you start the compressions. So look over here, guys. Look over here. Sequence in CPCR is what? First is what? scene safety. The first is scene safety. I forgot to tell you, first is scene safety. In any cases, first is scene safety. You ensure that the scene is safe to save the life of the person. Next, you check for the response. If there is no response, you call for help, and then you check for the pulse and breathing. Which pulse will you look for? Carotid pulse in adults. In infants, you look for what pulse, guys? Brachial artery pulsations. Okay, and once there is no pulse and no breathing, you start your CPR. In order to remember, this is SCCS. S stands for scene safety, C stands for check response, C stands for call for help, C stands for check for pulse and breathing, and last is CPR. When you are starting CPR, it should be high quality chest compression. That is basically what is the steps of the CPR. CPR when you are giving. Are you following in the CPR? Are you following the ABC protocol or CAB protocol? ABC is airway, breathing, circulation. CAB is circulation or compression. We are following CAB protocol, compression, airway, and breathing protocol. Okay, when you are giving compression, guys, you have to remember the number, the depth of compression, and the ratio. So number of compression, guys, how much should be the number of compression? It is universal 100 to 120 compressions per minute. What should be the depth, guys? 2 to 2.4 inches or 5 to 6 centimeters depth in adults. If at all it is infant, then it is 1.5 inches in infant or 4 centimeters. If it is more than 1 year, 2 inches or 5 centimeters depth has to be achieved. Or basically in infants, you can go for 1/3 of anterior posterior diameter while giving chest compression. What is the ratio, guys? Remember, 30:2. It doesn't mean that in 1 minute 30 compressions. No, in 1 minute 4 sets of 30:2 you have to give. Yani 120 compressions you will complete, and you also have to allow a full chest recoil while giving compression. Okay, now guys, what is the ratio of compression if there is a single rescuer? That has been a question. In adults, if it is a single rescuer, again you go for what, guys? 30:2 compression. In pediatrics, again, if there is a single rescuer, 30:2 compression. In adults, if there is a more than one rescuer, 2 rescuers are there, then also 30:2 compression. But in the cases of pediatrics, if more than one rescuer is there, operations you have to give continuously. The one who's taking care of the airway, what he'll do, he will give one breath every 6 seconds. He'll give one breath every 6 seconds. That is basically 10 breaths per minute. In case of pediatrics, in case of advanced airway, how many breaths should be given? In case of pediatric, if advanced airway is placed, then 20 to 30 breaths per minute. Yani ke every 2 to 3 seconds you have to give one rescue breath. One rescue breath. Okay. In case of newborn, what is the compression to ventilation ratio? It is 3:1. It is 3:1. Now guys, what is this? When is this position used? When is this position used? First of all, what is this position? This is called as a recovery position. And when do you use this recovery position, guys? Okay, how if the patient is having pulse, if there is breathing, but he is not responsive. Yani ke patient is having pulse and breathing, but he is unconscious. You make the patient in recovery position so that he does not aspirate the contents and all. Okay, this is called as a recovery position. Okay, next guys. Next question. During resuscitation of a patient in cardiac arrest, what is the correct dose and frequency of IV adrenaline in ACLS? Guys, remember, adrenaline should be given how much and how? Adrenaline should be given 1 milligram every 3 to 5 minutes in cardiac arrest. 1 milligram every 3 to 5 minutes in cardiac arrest. Okay, very, very important, guys. Okay, now we are just going through the algorithm. Remember, if the patient is having a shockable rhythm and if the patient is having a non-shockable rhythm, the algorithm is different. So, if at all the patient is having a shockable rhythm, what you will do? You will deliver shock. Okay? After 2 shocks, you will start adrenaline. And after 3 shocks, you start amiodarone. Okay? And if the patient is having a non-shockable rhythm, immediately you start adrenaline. Okay? Immediately you start adrenaline. So look over here. If you are giving adrenaline, how it should be given to the patient? The best route is IV. If IV is not possible, you go with IO, interosseous, as you can see in the picture, directly in the bone. If that is also not possible, if your friend has intubated, you can give adrenaline through the endotracheal route. What is the dilution of adrenaline in cardiac arrest, guys? In cardiac arrest, the dilution is 1:10,000. Yani ke 1 gram of adrenaline in 10,000 ml of water. Okay. Next, in local anesthetic, it is 1:2 lakh. Whereas in anaphylaxis, it is 1:10,000. Sorry, 1:1,000. Okay. This is regarding adrenaline. Now, guys, next. A 40-year-old man has pulseless ventricular tachycardia. After first defibrillation and 2 minutes of CPR, the rhythm same persists as pulseless ventricular tachycardia. What is the next best step? Guys, remember what you will do. A patient is having pulseless VT. One time we have given defibrillation. What is the next thing that we need to do? A, B, C, D. I want your answer, guys. Before I giving the answer, I want your answer. Okay, most of you are telling. Most of you क्या भाई एक जना ही का ही आंसर आ रहा है. कोई B बोल रहा है, कोई C बोल रहा है, कोई A बोल रहा है. Okay, good. So guys, remember over here. Patient is having, first of all, we need to remember, shock is given for what two rhythms of the heart? Two rhythms which are shockable are either VT, pulseless VT, or either VF, ventricular fibrillation. A scribbling type of rhythm is called as VF. Okay? So the patient was having pulseless VT, we have given defibrillation, and after 2 minutes of CPR, we have checked the rhythm and we have seen the same thing. If you see the same thing, what is the next step that we need to do, guys? You need to give same defibrillation. You need to repeat the defibrillation. Okay? Remember, guys, after 2 shocks, in case of shockable rhythm, after 2 shocks, you start adrenaline. You give adrenaline. Okay? And after 3 shocks, you give amiodarone. Yahan pe to sirf only 1 shock was given. So, if 1 shock is given, you have to give next shock over here. Is it clear? Right? Guys, remember, in between of CPR and all, never is whenever you are giving chest compressions and all, do not waste more than 10 seconds. There should not be a gap of more than 10 seconds. Right? Now, when we are talking about defibrillator, there are 2 types of defibrillator phases, guys. One is called as monophasic asynchronous. Remember, in case of cardiac arrest, we are giving synchronized defibrillation or asynchronous. It is always be asynchronous. In asynchronous, there are 2 phases, monophasic and biphasic. If you are giving biphasic, it is always a single 360 joules. If you are giving monophasic, it is always a single 360 joules, and biphasic is always 120 to 200 joules. And shock is only given for 2 rhythms, VT and VF. Okay, this is for shockable rhythms. What if the patient does not have any shockable rhythm? Yani the patient is having a flat line. What you will do at that time? In case of asystole, which is flat line, or in case of pulseless electrical activity, a rhythm is there without any pulse, or non-shockable rhythm, what is the next step that we need to do? We need to continue compressions. We need to continue compressions and then give adrenaline as soon as possible. Adrenaline should be given as soon as possible. 1 milligram every 3 to 5 minutes. It has to be repeated. And then we need to rule out the reversible causes of cardiac arrest. So guys, remember whether shockable or non-shockable. In shockable, remember if it is shockable, first shock, after 2 shock, adrenaline, after 3 shock, amiodarone, as well as you have to rule out 5 H's and 5 T's in shockable. If it is non-shockable, then you continue compression, give adrenaline, and directly rule out the 5 H's and 5 T's. Chalo bhai, what are 5 H's and 5 T's of cardiac arrest? 5 H's. First H is what? Hypovolemia. Second H is what? Second H is what? Hypothermia. Third H is what? Hypovolemia, hypothermia. Third H is, any guesses? Third H is hypokalemia or hyperkalemia, right? So hypovolemia, hypoxia, hypothermia, hyperkalemia, and hydrogen ion acidosis. We have to rule out hydrogen ion acidosis. These should be ruled out. These are the reversible causes. If you reverse this, cardiac arrest can be reversed. 5 T's should also be ruled out. 5 T's means what? 2 T's related to the heart. That is cardiac tamponade or thrombosis. 2 T's related to the heart. Okay? And 2 T's related to the lung. What are the 2 T's related to the lung? Tension pneumothorax or pulmonary thrombosis. Last is toxins has to be ruled out. Toxins has to be ruled out. Okay, these are the reversible causes that has to be ruled out. Now guys, what else we need to remember? There are some chain of survival. If we follow that, the chances of recovery, the chances of patient survival are high. So initially we had chain of survival till this. And again, we have to recognize immediate CPR, rapid defibrillation, basic and advanced emergency, and advanced support and post cardiac arrest care has to be given. Now, what is the component that is being added to the new one? New thing is recovery. Recovery you have added. Okay. Now imagine guys, you were giving compressions and all, and now the patient has recovered. There is pulse. Once you achieve ROSC is what? Return of spontaneous circulation. What should be your aim? My aim would be what? I should maintain the patient's hemodynamics. I should maintain the parameters. Parameters means the saturation I have to maintain and all. And I have to maintain the airway patency. So once ROSC has achieved, pulse is present, I will manage the airway patency. I will manage the respiratory parameters. Yani ki saturation I'll keep 92 to 98%. PCO2 35 to 45%. Then hemodynamics I have to maintain. Hemodynamics means I have to maintain the MAP as well as systolic BP. MAP should be more than or equal to 65, and systolic BP should be more than 90 mm of Hg. Okay? Once I maintain this, I'll get a 12 lead ECG. In the 12 lead ECG, if there is some problem, I'll send the patient directly to what? Cath lab. But if there is no problem in the ECG, I will now assess how is the patient responding, whether he is responding or not. If he is responding, I'll send him to ICU because he had a cardiac arrest event. But if he is not responding, first I'll do some things and then send him the patient to ICU. What I'll do a target temperature management, guys. Target temperature management means what? If the patient is not obeying, I'll do a target temperature management, that is 32 to 36 degrees Celsius. That will decrease the cerebral metabolic rate. Hence the brain uses less amount of oxygen. Then I'll go for a CT scan and shift the patient to critical care team or the ICU. But if the patient is obeying command, directly I'll send the patient to ICU. This was regarding what, guys? This was regarding once you have achieved the ROSC. Okay. Now, guys, just a brief thing of tachycardia. Imagine a patient is developing tachycardia. Tachycardia algorithm, guys. Okay. Imagine a patient is developing tachycardia, right? In case of tachycardia, how will you manage? First of all, you need to determine whether it is a stable tachycardia or unstable tachycardia. Unstable tachycardia can be determined by the signs of instability. What are the signs of instability? HASIA signs. H stands for hypotension. If the patient is having hypotension and tachycardia, that is unstable tachycardia. Next, A stands for altered mental status. Tachycardia and altered mental status means what? Patient is having an unstable tachycardia. Okay. S stands for signs of shock. I stands for ischemic chest discomfort and tachycardia. That is also a sign of instability. A stands for acute heart failure. If the patient is having HASIA signs, he is having unstable tachycardia. Unstable tachycardia, the treatment of choice is always, remember guys, synchronize cardioversion, no drugs. Synchronize cardioversion. But if the patient does not have any signs of instability but still having tachycardia, then you can go for what? VABC, vagal maneuver, first you need to do. Then the management is for most of the stable tachycardias is adenosine. Initially we are giving 6 milligrams followed by 12 milligrams. VABC, B stands for beta blocker and C stands for calcium channel blocker. Okay. Next, guys. Last question. A 58-year-old post-op patient develops tachycardia and hypotension despite fluids. Despite the fluid and norepinephrine, urine output is 20 ml per hour. Which additional drug should be given? Guys, remember, patient is having fever, tachycardia and hypotension. यानी कि patient is in shock. ठीक है? When the patient is in shock, the first thing that we need to do is what? We try to raise his blood pressure by giving him fluid, a good amount of fluid. If fluid does not go, we go for inotropes. In the inotropes, we give norepinephrine. ठीक है? Our aim should be, I should maintain a MAP of more than 65 mm of Hg. But still, if it is not increasing, I add vasopressin. Still after adding vasopressin, nothing is increasing, I add adrenaline. If after adding adrenaline also BP is still not increasing, then what? Normally it will increase, guys. We keep multiple inotropes, it will increase. But what if the patient is having a low cardiac output, guys? If the patient is having a low cardiac output, you can go for adding dobutamine also. Dobutamine. Okay. So look over here. What is the thing that should be considered? If norepinephrine is not increasing the BP, you can increase the BP by adding a drug called as vasopressin. Vasopressin. So guys, these were a few important topics. Here, most of the things. Okay. So I had tried to cover most of the things of anesthesia. Hope it was a comfortable session, guys. Yes or no? It will be helpful for you. Okay. All the very best, all the very best. Give your best. Right? Okay. Okay. Okay, chalo guys. Take care. Good night. Thank you. I log off. Thank you. Thank you. So we'll meet on that day, guys. What day? 9th, I guess. 9th on this thing. 9th we'll be having the discussion, na? And hopefully all of you will be in a very happy mood. Related to anesthesia, no? Related to all the subjects. But in ARDS, basically what we do is patient will be having hypoxia. In case of ARDS patient having hypoxia, we add PEEP, which will recruit the alveoli, more alveoli, and improve the oxygenation. Okay. ARDS may we are giving, there is a strategy where we give high PEEP also. Refractory ARDS बोलते हैं ना, उसमें we give that. Okay, thank you guys, take care.